It's time.
Hello? Hello?
Hello.
Hi, Praveen.
Good afternoon. Good afternoon.
Good afternoon. Good afternoon.
Sir, good afternoon, sir.
Good afternoon.
Hope you are doing good.
Good afternoon, sir. Praveen, sir, good afternoon.
Yeah, Shivanshu.
Sir, good afternoon, sir. Good afternoon.
Good afternoon. So, shall we start the program?
Yes, sir, we are here, sir.
Yeah.
We can start.
Okay. First, we'll start with the case history. Professor Mani. So now today the plan is first one live surgery. We are going to keep it very simple. That's why we are keeping only straightforward 5 ports technique of sleeve gastrectomy to make the other people like newer people to follow easily, to make them to understand the each and every step of how to do the sleeve gastrectomy. And followed by we are having 3 basic lectures. One is the basic pathophysiology of bariatric surgery or metabolic surgery in weight loss and other metabolic syndrome controlment. And second thing is why, and the most interesting, the need of our topic, especially the debatable topic, and each and every conferences without any proper consensus, the hernia and obesity. And nowadays, it is commonly, it's a routine for all of us, either as a bariatric surgeon or a hernia surgeon. This is a routine practice of us. It's a we are seeing the patient hernia with obesity or obese patients with incidental hernia. So how we are going to deal with that one? Whether we are having any evidence-based follow-up to have a follow-up of what we are going to do with these type of patients. Yes, Praveen is going to present with the evidence-based talk on that one, followed by the technical tips of how to do concomitant repair. Specifically, sleeve with hernia repair, either IPAM plus or ETEP, RYGB with ETEP or IPAM plus, or OAGB, ETEP or IPAM plus. We are having a case scenario with video-based presentation, and we can go ahead with that one. Sir, your Any thoughts on this one? Moderators, please.
Yeah, yeah. Definitely, you are very right that nowadays, with the knowledge and with the event of better diagnostic modalities, we are finding much more hernias with obesity. And we have, like you, we have a good series of concomitant surgery. Definitely, we know that if if the patient is ready and if the situation is right, you can do a staged repair. But in our country, in our scenario, where it is very difficult for a patient to undergo two surgeries for two different pathologies at two time, cost is an important factor. And because of other factors, we all are joining concomitant surgery for bariatric and hernia, and we all have found good results. We don't. You have published a result. We are yet to publish, but we all have found that it's a good practice to join hernia surgery with bariatric procedures.
Yes. Shivanshu?
Yes, sir. Yes, sir. Good afternoon, sir. First of all, sir, thank you for having me here, and it brings me back to my alma mater and all the OT number 4 and 5 where we used to do the pediatrics. So many things, and as you rightly told, as Rajesh Srivastav sir has told, with the advent of so many new diagnostic modalities, and definitely with the increased intra-abdominal pressure, patients do have inguinals and ventral hernias, which can be done. And of course, the safe practice, as Praveen sir and yourself, sir, we already have published our literature. So you are going to elaborate in the future further down the steps. So we are looking forward for that, sir. Yes.
Good evening, Jan. Okay, you present again.
So, patient is a 33 years young female who is a homemaker by occupation, has come with complaints of gradual weight gain for 3 years, and she had no benefits with lifestyle modification in terms of weight loss. So, coming to medical history, she is diagnosed with the diabetes mellitus when she has come to OPD, hypertension and dyslipidemia. Her HbA1c is 8.1, fasting blood sugar was 187, LDL 118, VLDL 27 milligram per deciliter, and HDL was 34. Uh, History of postpartum sterilization 6 years back. Menstrual irregular cycles are noted in menstrual history. And her height is 157, weight 121.6, BMI 49.3. Stop bank score is 3, add diagram score is 6, and reflex disease questionnaire she had 0 score. So our final diagnosis is severe obesity with de novo diabetes, hypertension, and dyslipidemia. Planned laparoscopic sleeve gastrectomy. So we are operating in surgical OT5 GEM Hospital. Operating surgeon Dr. Sarana Kumar sir, camera surgeon Dr. Akhilesh, bariatric anesthetist Dr. Prabhakaran sir, anesthesia assistant Sumati sister, scrub nurse Sumati sister. Thank you.
Thank you. This is the first trocar. We have gone inside. And see, as usual, see, this is in a belly in the computer. Yeah, we have seen this one. Right. Okay. So I'm standing on the foot and side of the patient with the steep reverse Trendelenburg position on the leg split. And see, we have to assess the first xiphisternum to the umbilicus, and usually upper 2/3 and lower 1/3. This is the mark. Okay, so this is the xiphisternum. This is the head and side, and I am standing here, right? And always from xiphisternum, not more than 15 to 20 centimeter, or at the summit of that after inflating the pneumo. So we have to go exactly at the summit, not more than 20 centimeter. Otherwise, the end on view will not be obtained when you are doing the dissection close to the OG junction. And that's why not more than 15 to 20 centimeter, the first trocar. It's a blind trocar. And here our technique is, this is the midline, right? And first away from the midline, minimum 3 to 4 centimeter away from the midline on the left side of the patient, first camera trocar, because most of our dissection will be on the greater curvature side. And when we are placing this 10 over here, and mostly that falciform will be the hindrance for us. And that's why if you are placing little bit away and you are away from the falciform, and most of the dissection over here, exactly at the OG junction, that's why the first trocar followed by one liver retractor, and I'll show you accordingly. And once you have gone inside, there is not much of adhesions, right? But if you are looking at liver,
Dr. Sharan,
definitely
how did you did neoperitoneum?
so the closed varus needle technique.
Okay.
Closed varus needle technique by the keeping the pressure by 20, and it allowed only 1.5 to not more than 2.5 liters per minute, that varus needle. Once being completely inflated, I have reduced to 16 pressure now, and this first is a blind trocar, and I have made inside, and there is no obvious injury, and there is no adhesions too, right? And this is the first trocar side, sir.
Sir,
Right?
there is Sir Jayant here,
So
sir.
can we,
Sorry.
yeah, yeah, then sir, please go on, sir.
Hi Shivansu, how are you?
Hi, sir. Hi, sir.
Hi,
Saranakumar
and
sir.
yeah, Jayant.
Hi sir. Sir,
Hi, doctor.
there is always a big apprehension among young surgeons when they want to do a pneumo of the of a large obese abdomen, right?
Yes.
So what is the tip that you can give them when going on a closed varus needle technique in a obese abdomen? See, because usually we catch hold of the stomach and we tend to do a counter pressure with the varus and pierce the fascia. But in this case, what would you what would be a tip for the younger
Yeah.
surgeons, especially in such an obese abdomen?
Yeah. Usually, see, we cannot able to catch hold of the anterior abdominal wall, especially in this type of patient, because of the thick anterior abdominal wall as well as that fat, and that's why always better we can have a pressure. See, you are able to see from outside either focus panel. By giving pressure on either side of the loins, right? Okay, lateral abdomen wall, giving a thrust like this way, giving a pressure and the assistant surgeon on this way, make a doom of that anterior abdomen wall here, and because of the thick abdomen we cannot hold like this way. So just to give a pressure, and by pressure and gentle push into that by varus needle, and by one and second click you have to stop that one. Once being inside, and make sure that it is inside by the saline infusion test. And second thing is, once that CO2 is connected, usually the pressure will be on the higher side because of the pressure exerted on the external pressure by us, and usually around 10 to 12 mercury. Don't worry about that one. See the flow rate. If it is around 1.5 to 2.5 liters, then that means it is inside the intraperitoneum. And by slowly, once it reaches that 1 liter inside, when you started releasing the pressure, automatically the pressure will drop down to 8 to 10. Then we have to allow this pressure up to 20 This is the way of doing this one.
Sharna,
Right?
we always use OptiPort for first procar entry without varus needle. How
Yes,
about what is your opinion about that?
Yeah, so it's all depends on experience and how you are gaining your experience on the particular technique. There is no hard and fast rules. This technique is superior than that other technique. And here, our chief always prefer. He has done more than 1 lakh cases with closed varus needle technique. That's how we also got trained ourselves, and that's how we got trained. And there is no harm in continuing with either open Hassan's technique or opti-trocar techniques. All depends on experience, how you are gaining over the period of time.
Okay.
Good afternoon, Dr. Kedar Patil here.
Hi,
Saravana.
Kedar. Good afternoon. Good afternoon. Welcome.
Just one tip I would like to inform to the listeners that
Yeah.
in obese patients, preferably one should try to avoid going in midline or to the right of the patient, because the chances of miscalculating the abdominal wall width are high, and you might hit the mesentery or retroperitoneal structures. So, what Srivastav sir was mentioning, we do a combination of both. So we do a varies along with the OptiView entry, but it is in the left lumbar region of the patient.
Okay, okay. Points well taken, Ketar. And so this is the first trocar. Exactly, see, liver is too bulky, typical of MAFLD, metabolic associated fatty liver disease. Even though patient is on liquid diet for almost 5 to 7 days with the loss of weight, there is around 3.5 to 4 kg, still liver is too bulky, right? And this is the first trocar exactly opposite to the incisura and opposite to the greater curvature. And the second trocar here, see, lateral to the and the first trocar, it shouldn't have any hindrance to that first working trocar, and it is away from that one exactly, probably on the left anterior axillary line for the retraction and helping out here. And this is final left hand working trocar, more or less 12 trocar for my uh, staplers and all. See, it is come just juxtapylorus. You can see here juxtapylorus, and usually after making with the bougie insertion, and we can have because you can see here. See, stomach is J-shaped stomach, and most of the dissection over here and the greater curvature. And after placing the bougie, and it hold pan my it push then. See, my left hand is coming like this way, and most of the staples from the left hand, there is no need of one more 12 for most of the sleeve gastrectomy. If needed, I can make use of this one as a 12 if needed, or mostly this 12 is more than sufficient and to make a complete endostapler, right? And first step is always we have to decompress the stomach as part of the any upper GI or bariatric surgery. And this is the Riles tube. Suck பண்ணுங்க complete. Make sure that you have to decompress all the fundus, because we have to take out the fundus while taking. If you are leaving behind the fluid over there, வெளியே எடுத்துக்கங்க கொஞ்சம். It will be difficult while dissecting the fundus close to the fundus, and there is a tendency of leaving behind the fundus posteriorly. So that's why we have to take out this fluid completely. And while removing the specimen also, if you are leaving behind the fluid or gas, it will be very difficult. So that's why decompressing the step, stomach as a first step. Come. And my next step is, this is the incisura. Opposite to the incisura, hold the stomach nicely, retract like this way. You can see a nice plane over here, and that is the point of entry into the lesser sac. Harmonic call pakkathulama.
இல்ல இன்னும் வீடியோ வர மாட்டேங்குது.
Don't give any pressure. Don't try to dissect anything over here. Just try to apply the harmonic over here. Try to enter into the lesser sac without dissecting much. So once you have entered, see, now we can see that
But
lesser sac.
Your choice of energy source is harmonic always.
Mostly harmonic. Yes, sir. Either you can use a harmonic or ligature. Depends on the convenience of this. And both the instruments are too good, sir.
Right.
And I am going very close to the greater curvature. Not too close, not too far away. Not to injure the seros also. If it is injuring, there will be a bleeding. Otherwise, no issues. Or if you are going too far away, and gastroepiphytic vessels will come, chance of injury. So that is why not too close, and you can have a nice plane over here. Exactly, we are going close to this one. There is no hard and fast rules that either you have to go down first or up, or first or next to down. And if you are convenient, then go down or up, depends on that one. See here, my left hand is giving a nice traction, upward thrust, and this is the posterior gastropancreatic attachment.
Saravana Kumar sir, we see that you have a very nice eagle's eye point of view. There is not an end on view. So your camera surgeon also doing very great job,
Yes,
sir. Having a steady hands, and it's a head on view, not a head on view. Basically, it's looking that we are looking from somewhere above.
yes.
That is very
Again,
important because sometimes we may misjudge and put the camera port quite down, and that may end up in end on view, and that may cause some
yeah,
problem. But here it is showing very nice view, as we can see.
yeah,
Appreciate that.
because Achilles is one of the beautiful surgeon too. That's why he knows how what is needed for me,
Yes,
and he is able to follow.
yes,
There's always a
yes,
synchronous movement between the surgeon, staff nurse, and the assisting surgeon,
yes, yes,
right? And
yes,
moreover, see if you are having any doubt, suppose because always the first trocar entry is the blind trocar entry, and if you are thinking that it is too far away or too close, don't hesitate to make sure that under vision. See, you can make one more 10 mm trocar. Otherwise, you'll be having the struggle
yes.
always. Okay, don't hesitate to place if needed one more trocar. This is the pylorus tentatively. So I have come closely, and let me go a little bit further.
And you have removed the all the posterior pancreatic gastric
We have to
attachments.
remove. I'm not removed completely,
Yes, yes,
and
yes, sir.
I'm going on.
Yeah, it is.
Yeah,
Yes, yeah,
Funny
yes.
case, pylorus is attached with gallbladder.
yes. And we can stop it here, and almost close we have reached. And if you are doing a sleep DJB, yes, we have to go down and reach here and reach the gastroduodenal artery. And these are the small gastropancreatic attachments. We have to release completely. So close a little bit. Okay. Yeah. See, there is one more lateral attachments here. I'm not going to remove this one, because it's not going to have any hindrance to my dissection, because my dissection on the greater curvature side, and these are the unnecessary steps. Just leave it like that and go above.
But every time it will come in your field. So why don't you remove this?
Yeah, yeah, no, no harm in removing that one, sir. But
Yeah.
uh, and if needed, we can remove it.
Yeah.
Otherwise, see, I'm going away from that one. Once this being done, it's going to lie down on the floor.
Yes.
See, my left hand is doing most of the surgery than the right hand. Right hand just applying this one, right? And I'm giving giving a pressure like, a lift like this way, going up, seeing that. See, now I'm giving a traction towards the midline. Active blade on the vision side, because I know where I'm exactly hitting on that one.
Right.
Till now, I'm doing the fast mode, and I'm adjusting with my left hand. See, now I have to give a, see, once the vessel is there, I'm relaxing my left hand. That is most important. Okay. Now we have almost close to the short gastric vessels by giving a nice exposure over here. Don't be in a hurry over here. and relaxing my left hand. That is most important.
What instrument you have used for lever traction? It's lever rod.
So this is nothing but small needle holder only, sir.
Okay.
And you usually will prefer to do with 5 trocar. We are not using any Nathans and all depends on how we are practicing. And
Yes.
this is where very useful, because at any times if you want to retract like this way or retract here when you are doing the anastomosis or cardiac loop dissection, so we can have adjustment. Whereas Nathans and other things and all will be having it's a fixed point only. That's
Right.
why we have preferred to do this one with the
Right.
5 So now I have to see the posterior aspect. Now I have flipped the stomach such a way that I'm not going there. I'm starting from here. So the posterior gastric artery vessel, which is draining into the splenic vessels. I think Sivan Singh has already published on this one. More than 60 to 70% it's a constant finding when you are doing any sort of upper GI surgery, and it has to be
Yes, it
taken out.
was a yeah.
Yes,
The relevance of the posterior gastric vessels in bariatric surgery.
yes,
So we have a publication from GEM Hospital, and
yes.
that's
Without taking that one, sometimes we may have that leaving behind the small part of fundus over there. So that's why it is mandatory to dissect out. Make sure that you have to remove this one.
sir. One thing which I wanted to ask, what
Yeah,
that like when you are giving this, like you are close to the short gastric vessels here.
yeah,
So any particular precautions or like hint, like advice you would give to the
yeah.
young people,
Yeah, that's
like
what
because
I,
yeah,
I informed her. Like, see, whenever we are going close to this one, slow mode, and always make sure that you have to leave behind the left hand traction. Don't give a
yes,
traction and cut that one. Okay,
yes,
and
yes,
this is the left crest,
left
right?
crest, yes, yes, sir, yes, sir.
Yeah, we have to release up to the left crest completely. So once I've released that posterior gastric vessels, I'm able to see this left crest nicely,
Yeah.
and I think this is more than sufficient,
Sir,
right?
don't you feel that in diabetic patients who are diabetic, those people will have more like chronic angry fat, chronic inflammation, more posterior attachments like that. What do you feel from your experience, sir?
So no posterior attachment not depends on that metabolic syndrome.
Diabetes. Yeah,
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 yeah, but the chronicity of this one, because of the, so if you are looking at these patients will be having that the CRP will be on the higher side always,
yes,
because it
yes, yes,
stating that's a chronic inflammatory condition. But
yes,
so
yes.
yes, of course, not the posterior attachment, but the omental attachment and the OG junction part of it, definitely it will be there.
Will be
Now,
much. Yes.
yeah, now we can appreciate it's a complete detachment from the pylorus to here. There is no posterior attachments over here, except a small area over here where I can. Yes, right. Yeah. Booji push பண்ணுமா?
Which size boozy you are using?
So routine gastric calibration tube. Gastric calibration tube from the Ethicon. It's around 37 French bougie. That is standard gastric calibration tube in GEM hospitals, sir.
Okay.
And one thing, it is not too small or not too far away from the size of the bougie shouldn't be less than 32 or more than 40. That is the recommendations, consensus statement and sleeve. Right. Bougie ulla push pannu. Okay. So bougie is coming inside.
Sarvana Kumar
Yeah.
sir, can you show the upper limit of dissection for the
Okay.
beginners? Because sometimes the complete dissection on the upper end is not done and the
Yeah.
fundus gets left behind. So
Yeah.
can you show, I mean, once this is fired, can you show the upper limit of
வெளியே
dissection?
இசோபேகஸ்ல வை லெஃப்ட்ல கொடுங்க. I'll show you, right? So this is the fundus, right? And this is the OG junction pad of fat. So this is the OG junction. This is the OG junction pad of fat. I'm flipping the stomach opposite way and holding the posterior wall like this way, and you can see nicely. Okay, so that's why that posterior gastric vessels has to be, and this is the left crus.
Yes.
Okay, this is the limitation, and that attachment completely taken off here. There is no further attachment. See, you can see here,
Great, wonderful.
right?
So the idea is you have to see the left crust before you
Yes,
feel that it's
exactly, sir. And this is the splenic vessels. Splenic vessels.
The white line at the junction of the
See,
crust and the OG
this is the one.
junction.
Okay, right.
this is the V
And,
junction.
and
Beautifully demonstrated.
இப்போ உள்ள push பண்ணுங்க. And now I'm going to use the Ethicon endostaplers green, because antrum is the thickest part. See how to guide this one. Come back. Camera கொஞ்சம் push பண்ணுங்க. So now they have pushed the
Thank you.
push பண்ணாத வெளியில. See, they have pushed the bougie inside along the lesser curvature, right? Now I have to adjust with my right hand pushing this one and make sure that this left hand, that with this one I have pushed inside. Now under control I have asked them, inna push பண்ணுங்க கொஞ்சம். Okay, they are pushing inside. I am same way I am adjusting and holding the exactly at the greater curvature side. Push பண்ணுங்க. Push பண்ணுமா? Okay, போதும். அந்த எடுமா இடிக்குது. Now I'm giving little bit traction and adjusting. See, by giving a thrust on this one and pulling this one. Okay, and again I'm going to adjust little bit slowly. This will be little bit difficult because of the J-shaped stomach already evident by during the surgery itself. And கொஞ்சம் வெளியிலுமா?
Sarvana, we do little different. We don't put the bogey for the first fire.
Yes, sir.
We do the first fire and then we put the bogey, because then distance between pylorus and your first fire increases when you fire with bogey.
Yeah, that's why. See, this is the pylorus.
Good.
And this Z line. So inge come down. This Z is no here.
Yeah, right.
The Z line is 5 centimeter. I'm exactly at almost 3 to 4 centimeter from the pylorus stretched point, and usually I'll adjust little bit like this way and giving a pull like this way. Okay, push பண்ணுமா லைட்டா. First gas போட்டுருங்க. Right, fantastic. So the most important aspect is always look at the incisura.
Yes.
This is the most important area. Always we have to insert one tip of the instrument over here, because we are going too close. Automatically it's a stretched stomach. Automatically it will go for stenosis, and eventually can cause stenosis, obstruction, proximal dilatation, and inadequate weight loss or recurrent vomiting. That's why this is the first step. Always we have to at least 0.5 to 1 centimeter away from the incisura and flip like this way. See here, and it's always away from that one, and you have to see inside down also, because we shouldn't include any of the tissue over here or the pancreas, right? And wait for always company recommendation 15 seconds, but usually in Gem Hospital we'll wait for 60 seconds. And this is a Ethicon endostapler by GSC technology, gradual sequential compression, so allowing tissue fluid to get dislodged and for proper smooth firing. And can see here அடுத்தது. So starting by yellow, golden yellow rendu, always try to take out the crutch, that is unfired stapler in between this one, and it can cause misfiring of further stapler. And since the stomach from pylorus to antrum to fundus, which is the thickest part to the thinnest part, so color coding in Ethicon, starting with the green, followed by 2 or 3 golden yellow, and finally to the fundus blue, that is the thinnest part. And whereas in other Medtronics tri-stapler, they are having tan, purple, and black. So tan is 2, 2.5, and 3, whereas before B configuration. And see, same way, make sure that not too close, too far away, and like this way. See here.
Dr.
And
Sharma, how about firing all the purples?
sir,
Uh, have you used purple, only purple in sleeve?
no sir. Always we have to use either black or this one, like Ethicon green stapler for the antrum. கொஞ்சம் வெளியில புல் பண்ணும், கொஞ்சம் வெளியில புல் பண்ணும். Okay, வச்சுக்கோ. So, because in purple 3.54 mm will be there before B configuration, and whereas tan is 2.53, and black is 4.55. If you are using Medtronics or Lotus, if you are placing this black, then you might require 15 mm of trocar, whereas in 12 mm trocar, that black will not be go easily. So we have to change the trocars. And whereas in if you are using Ethicon green stapler, that is 4 point, now they are saying 4.3. So always preferably green or black in Covidian for antrum, followed by purple, all purple in tri-stapler, or 2 or 3 golden yellow, or followed by blue. So I'm not see, just giving a traction on the greater curvature side. Don't give a pressure like this way. It can cause more on the anterior wall, or if you are giving a pull on the posterior aspect, it will give on the posterior effect. So before, make sure that make the normal alignment of the stomach like this way. Let it be lie on this one, and by adjusting the only that other side of the stomach, just giving a gentle traction on the greater curvature side, gentle push. That's it.
रेस्ट करना है
Stomach little bit thicker than comparatively other cases, so I am planning to keep one more. Either we can go ahead with the golden yellow or blue. I am planning to go one furthermore yellow, followed by blue over here. The one point is here, if you are using a yellow over here, it may cause sometimes bleeding because of the thinness of the stomach. But erring on the bleeding side than the leak, always better. That's why I'm going to keep yellow next one also. You can see here, nice GST technology by the Ethicon. And look for this, see, crotch, like this way. Try to take it out. Make sure that that stomach, see, should be in the normal straight line alignment. There shouldn't be any twist. So I'm adjusting on the other side only. I'm not catching on the this side of the staple. Till now, I have not used any articulation on this one with the placement of that stapler straight line. It's going very straightly. That's why only one right sided 12 trocar is more than sufficient for sleeve gastrectomy. And see the final stapler also. See, if you are coming from the left hand side of yours, that means if you are using a right hand 12 trocar, then automatically it will go towards the OG junction, the stapler. And when you are using from left hand, it is going automatically away from the OG junction towards the upper pole of the spleen, which is most important, because if you are going close to the OG junction, to the esophagus, injury to the esophagus is common, or if you are going too close, can cause leak also. Right? That's why this left hand working trocar for the stapler always having a better alignment for stapling. Blue. So I'm looking for the crotch again. And so now the most important is like the fundus. How to exclude the fundus over here? See, I'm not done anything, just inserting my stapler, and with the right hand just, and because already I've dissected nicely, and you can see all the fundus on my right hand side. See, you can see don't give it too much of pressure or pull, right? And let it go. See, it has gone completely. And make sure that all the fundus the side, and don't give it too much traction like this way. Let it lie on its own. Okay, this is most important. And make sure that this is the OG junction pad of fat. I have not dissected the OG junction pad of fat, because usually you start dissecting this one, and there is always tendency going close to the OG junction or esophagus injury more common. Unless it is hindrance to your staple, just leave it as such. Say, I'm not dissected. That's why this is the virgin area, OG junction, and it is going away from the OG junction. And this is important. And see, towards the spleen. So don't try to save the staple by giving a pressure like this way. Let it be like this way. Okay. And I'm trying to adjust from here. And if needed, I'll place one more trocar and go close.
So how close you want to be from OG junction?
See, actually, at least 1 centimeter away from the OG junction.
Okay.
Or leave behind the pad of fat and coming away from that one. So you
Yeah.
can see this is the OG junction, and this is the esophagus. You can see, and I can see nice 1 centimeter of tissue over there. That is stomach is over here, right? This will not cause dilatation or weight gain. Mostly the fundus, right? And see, this is the mark. So usually I might require one more 45 or 30 mm, or otherwise I can use one more stapler to prevent that one. Most of the people giving a traction, pull, and crumpling on here can cause misfiring over here. So always we have to very gentle movement in this area when you are doing the stapling. See, I have not touched the tissue too much, right? Gently I have done that one. I have come out of that one. And one more important thing is, don't happy with the bloodless field. That is very dangerous post-operatively, especially in sleeve stomach. And always make sure that you are, say, after making all the staple, see here, and don't put any clips over here and try to divide this one. Always erring with the staple on the higher side of the staple than the clips, because once it leaks, it can cause too much of a problem for the patient and the surgeon for us and post-operative management. Rather than, see, one extra, that is this trocar around 10 to 15,000 will save 5 lakhs post-operatively. So it's gone beyond that one. Make sure that don't injure the spleen. Don't give a pressure like this way. Just make sure that let it be. I'm not to give it too much of traction. If you have noticed that one, always I've made a very gentle movement only. And final firing, see, it has to come out on its own, right? Nicely it has done. And you have to go and see this one. Yes, completely done. There is a small bleeding, nothing to worry, let it be. And we should be happy with the bleeding perioperatively than the postoperatively. So that's why we'll ask our anesthetist to push the uh, BP at least minimum of 20 to 30 of from baseline systolic and to make sure that there shouldn't be any post-operative bleeding, to identify the any small pulses are there, we can make sure that tackle on the table itself. This is our routine protocol. It is not always mandatory, and make sure that we are closing that upper one third of the stomach or 3 to 5 centimeter with the omentopexy, right? And this is to prevent one one is hematoma, and it makes sure that the normal alignment to prevent the twisting, and the hematoma eventually the abscess and the leak. So you have to go take 1 second.
Shravana, we always implicate 2/3 of our step line with sutures, and we do omentopexy.
Yes, sir. Yes, sir. But there is no consensus statement.
I
But
know,
it
I
all
know.
depends on the individual practice. But we are practicing routinely upper one third, and see, always go beyond that staple line. Okay.
Is barb suture here your suture of choice all the time, sir?
No, it's all depends. See, either you can use either PDS or Maxon, or this barbed sutures will be giving a little comfort while doing the suturing in close to the OG junction, where it can have the gripping technology and it can hold the tissue nicely. That is why. Otherwise, it's not it's not mandatorily the using the this one. Either PDS or Maxon or bobbed suture. This is from is 20 centimeter length, which is more than sufficient for the upper one third for 3 to 5 throws. And this is a 20 bobby from the lotus. And this is the triangulation technique usually we will take to bury the. Don't include the staple line. That means that is not thrown through the staple line. And when you are taking the bite also, don't take too far away, because already there is a bougie is there and we are close to the bougie, right? And if you are taking too far away, that means you are again the lumen is compromising. And just go ahead with that free alignment of momentum. Just take a bite. Since it's bleeding, I'm okay. Suppose the patient is with antiplatelet or any anticoagulant for lifetime, and if you are expecting bleeding post-operatively, then close the full staple line with the sutures with the ometopexy, or otherwise upper one third is more than sufficient. Or if you are not closing that one also, it's not going to make any harm on this one. But it is our routine practice. We are using almost for 10 years down the line now. And catch hold of the anterior stomach wall like this way, and small posterior close to the staple line. Don't disturb that one. And will entry just perpendicular to that needle is just perpendicular, and make sure that make a curve, and it has come out. So this is the advantage of having the bobbed sutures over here
It
to
helps
hold
in
nicely.
keeping the sleeve straight. That is one.
Yeah. And this is a 20 centimeter, which is always very handy when you are doing a laparoscopic sutures. And usually when you are doing any sort of sutures, don't use more than 35 centimeter for any anastomosis. And if you are started using more than 30 centimeter, and the handling of sutures will be very difficult. And see, when you are doing this suture, one more thing, suppose if you are left behind part of the posterior wall or anterior wall, and if you want to make sure that should be in the normal alignment, can be included in that suture line, and that's also one more added advantage when you are doing the omentopexy or sutures.
Sir, Sarvana Kumar, sir.
Yeah, Shwansu?
Sir, sometimes like when you're taking the bites and you end up in having some bleeding spurts. So you just keep on doing it. What will be your advice for that, sir?
Suppose there is any bleeding, just give a, because that's why the bob sutures, just give a pressure and wait for that one, assess that condition. If it is through, usually, see, if it is taking here, automatically there will be a chance of bleeding over here, right? And suppose if it is a bleeding, wait and give a nice pressure, wait for 2 or 3 minutes. And even if it is bleeding beyond that one, again, try to take the figure of 8 or keep the clips with you. Just apply the clip on that one.
Yes, sir. And usually with the like when you are imbricating the momentum, so that tamponade effect itself will for some time will cease,
Yes.
slow down the bleeding and stop the bleeding.
Yeah, that's what I'm trying to say.
Yes, yes, sir. Yes.
Yes.
Point
Yeah.
taken, sir. Yes, sir.
Clip. So you have,
The baseline is there should not be any bleeding.
yes, you have to make sure that there shouldn't be
You
any
cannot leave
pressure.
a bleeding point behind.
Yeah. That's why should be happy with the perioperative bleeding than the postoperative bleeding.
True.
Clip. ಇದು ಸೀಸರ್ ಗೊತ್ತಲ್ವಾ? And okay, that's it. I'm going to take it out. Yeah, always under vision, make sure that counts. And now இங்க இது கொடுத்துருங்க, பவுல் ஹோல்டிங் கீழே. So exact at the junction of the two staple line or the bleeding point, my clip. So here there is a small bleeding point. I'm starting from here. Now they have raised the BP from 100 to 125 already, and because I'm coming close to that ending point of my surgery, so that is a synchronous movements by our anesthetic assistant. Already they have started increasing the BP. And so these are the spotter's points. Make sure that there shouldn't be any bleeding. Shit. My left hand is not allowing to place this one. Let me see. ಇದು okay. Okay, good. ಕೊಂಡ. ಹ? ಅದ.
Usually we shift the camera and do this step with our right hand.
Okay. But we are not changing the camera position as such, sir. And because we have trained our left hand in such a way that both the right and left hands are working together nicely, tandemly. That will reduce the surgical time too. So surgical time should be calculated not on the fast movements of this one, rather than an unnecessary untoward movements during the surgery. That makes lots of time will be saved. So always, as a youngsters, my advice to take home message is always don't copy with to do the fast surgery rather than the neat, slow, steady surgery. Right? That's all done. Now I'll ask my anesthetic assistant to take out that.
As you have, sir, Sarvana Kumar, sir, you have rightly told, slow is fast and fast is slow. I would just like to add on one sort of phrase that dress me slowly, I am in hurry. So if we whatsoever hurry we are in, if we go slowly and step by step, everything becomes automatically fast. You have done a very meticulous job, sir. Very bloodless field and nice, great job, sir, as usual.
The saying is go slow to reach fast.
Yeah, yes, sir.
Yes, sir. And see, you can see a nice this thing straight line over here. And how the final important step is just to place this momentum this way. Let it be, and it will go form a new this one. Mark it down, Panikyo. Head down, Panikyo.
Sir, Sarvana Kumar, sir, Prabhakaran, sir, is there?
And see, now we have to take out the
Sarvana Kumar, sir. Hello, Sarvana Kumar, sir. Hello.
Also,
Hello, Sarvana Kumar, sir.
Shivansu, I think just hearing you say, ask him, I think he just ran out of the theater.
Yeah, I think. Yeah. Okay, no problem. Jayan, sir.
Yeah, Shivansu.
What next? I think so. There are some discussions. I suppose no after this surgery.
I was just checking.
Pradeep, hi.
Hi, sir.
Then, sir, we are like almost done with that paper. No, Taret paper. You had got the mail? No, you had not got the mail.
I got the mail, I think.
It is the revision number 5. 4 revisions already, right, sir. Every time it's coming from the obesity session, and I have to finish that in time. I don't know how I'm managing it. But most likely it should be published. Good to see you.
Yeah, it's been a while, no?
राजेश सर आपको कैसे हैं सर राजेश सर
एकदम फर्स्ट क्लास. How are you?
फैंटास्टिक सर हाय केदार सर
Kedar. Hi,
Hello,
Kedar.
everyone.
All well?
Yes, all good, sir. That was a very nice demonstration by Dr.
Wonderful.
Sarvana Kumar. I think he showed all the steps, essential steps, and important was, as you discussed, slow is fast for a sleeve because it's going to be a lifelong thing for the patient. I think having a straight line, a stapler line, is one of the most important key factors in this sleeve.
Yeah,
You
you
are
are
so, sir?
100% right.
And just for the sake of discussion, if you could add some key points where people go wrong and cause a twist, or the technical important highlights of a sleeve, if we could highlight.
Basically, what is important, what Sarvana has shown, the fundus should be removed. Many of the times we have seen weight gain is a rule after all the sleeves. There is no whatever technique you use, that is okay. But if you do improper sleeve, the weight gain will be very fast. If you leave the fundus, that will be a problem. You have to be very careful at OG junction, because when you separate the stomach from spleen, that is again a very important part. We have seen people taking out spleen because they damage the short gastric. So there you have to be very careful. Then again at the pylorus, you have to be very careful. You should not leave more than 5 centimeter at the pylorus. So these are the basic tips, and of course, cleanliness of the surgery, and what Sarvana has showed beautifully. Respect all the vessels. When you see a larger vessel, there is no harm in going slow. What he showed in his live presentation. So when you reach up to the at the area of spleen, you become slow. Otherwise, you go fast. So these are the few points which are very important, and he has imbricated the 1/3. We usually imbricate 2/3 of the staple line. In the same way, it helps in straightening of the sleeve. You attach the momentum to the greater momentum, greater curvature as it was earlier. So these are the few points. Otherwise, sleeve is not a big deal. It's a very simple surgery. There is no CVD in sleeve.
Yes, sir. Beautifully, beautifully explained, sir. And finally, now the important aspect of taking out the specimen out through the 12 trocar. Just I have dilated a little bit, and by catch hold of that this one antrum part, right? I'm by giving a nice traction along the greater curvature like this way, by little bit twisting like this way. Don't give too much of this one, right? Okay, and under vision, see, so that's why first step always we have to decompress the fundus by the Rice tube. Right now it has come out nicely, and make sure that delivered a baby, nice baby now, right? So make sure that there is no leakage of this fundus over here, taken out completely, right? And this is the betarin, and this is 12 mm. That's why I'll prefer to do a transfacial closer over here. Okay, catch. நீ வந்து பிடிமா அவரை ஸ்ட்ரைட் பண்ண சொல்லி கேமராவை ஓகே பிடிச்சுக்கோங்க ரைட் இல்லை
Sarvan Kumar sir, at the end of it, can you please show your port positions again for those who joined it
definitely.
late?
I'll show you. Right. நம்ம அந்த டொக்கார் கொடுத்துருங்க. That's it. போதும். See, one is more than sufficient, there is no air leak. Okay, and the suction போட்டு அதை எடுங்க. And okay, okay, மேல மேல அவன நீ பண்ணுமா.
So are you going to close the 10 mm port as well similarly?
Sir, usually 10 mm port doesn't require, and but always preferably closing that one, because in obese there is no requirement of closing the 10 mm, but preferably if you are closing, having the habit of closing that is always better, sir. Right? And போதும் அப்படியே வச்சுக்கங்க. See, that's all over, and I'll show you the trocars now finally. Okay, see, have you seen this one, the beautiful camera person? Because this is the first time we are taking out from the intra-abdominally, and this camera, that means he is not too close, not too far away my dissection, and that's what the surgeons, camera surgeons, synchronous movement is always mandatory, right? And this is the head and side of the patient, and I am standing in between the legs, and after giving the steep reverse Trendelenburg position, we have to do the surgery. And this is the xiphisternum, and this is the umbilicus. Usually left side of the abdomen, that is 3 to 5 centimeter away from the midline. 3 to 5 centimeter away from the midline. First trocar Nemo, either by Verus needle technique or opti-trocar, depends. And with that, once being inserted and the by Nemo inflated, that 10 mm trocar, this is the camera trocar. And after that, depends on, see, this is the standard 5-port technique. Either you can use either 3 ports technique also, where need not to use this one retractor trocar, and this liver trocar, maybe we can use the liver suspension technique. 3 ports technique also feasible, but this is standard 5-port technique. One camera and one is for liver retractor. Under vision, depends on the shape of the liver as well as the stomach, we have to place the other 3 trocars. There is no fixed point to make the other 3 trocars. Also always depends on the liver and the stomach status, and this is just opposite to the incisura at the greater curvature. This is just lateral to that right hand working trocar, not having any hindrance while doing the dissection or working right hand working trocar. You slightly on the left anterior axillary line, and this is only one 12 mm trocar for sleeve gastrectomy or sleeve DJB or even OAGB NGB. This is our standard port techniques, and except we'll place one more 12 mm trocar in the OAGB here, otherwise only 12 mm. This will be used for routinely as for me doing D2 subtotal gastrectomy also. So I'm always training my left hand as if I'm doing on the right hand too, and this is on exactly juxtapylorus along the greater curvature, and that's why our staple line will go like this way and up to the OG junction, away from the OG junction. This is the standard 5-port techniques. Is it clear?
Yeah, wonderfully explained.
Oh, thank you.
Yeah, thank you.
Thank you. And now this is the time we can start the lectures. And Pradeep ready arkanla? And the Prabharan is here. Shivansu, Prabharan is here, and he'll teach you some technical tips of anesthetic aspects.
Hello. Yeah.
Prabharan is our actually
Hi, Prabha, Jayan here.
anesthetist over here.
Hello. Hello, Shivu. How are you?
Shivu asked for you and he was waiting for you, but he couldn't find you with sadness. I think he's not there.
Hello, sir. Jain, sir. Yeah. I was here. There was another case which required help. So just for a brief time, I went there. So from anything technically, I mean, apart from the regular optimization, this patient is always okay. She's except that say super obese, we optimize. She's not having any OSA or OHS. The ABG is fine. Clinically, the Stop-Bank score is less than 4. I think so. It is 3. So we didn't put her on CPAP or BiPAP anything. She didn't require, even though she is in a super obese, she's not having any OG or OHS. So we optimized quite for a few days, like 10 days with aggressive spirometry and breathing essays. That alone had improved her effort tolerance. The baseline saturation was around 92, 93. And today, that was about 2 weeks ago. And today, while I was seeing her, she was okay. The baseline improved to an extent of 97 to 98. So even a good spirometry will achieve your improve your FRC. That's what I was trying to say. So
What
that's
is
it.
the threshold that you
Yeah.
have? What is the kind of threshold that you have on for a patient who's preoperatively you have put on BiPAP or CPAP for OSA or OHS for whatever reason. But what is the threshold that you have that you use this BiPAP or CPAP post-operatively, immediately after bariatric?
Okay. Immediately, if the something what to say, if the patient's Stop-Bank score is more than 5, where your classification of OSA comes into moderate category, moderate OSA, like Stop-Bank score of more than 5 or 6, definitely those patients will require BiPAP or CPAP, whichever the patient is on preoperatively, to be continued in the postoperative scenario also, because most of the time these patients might land up in any sort of type 2 respiratory failure or increased CO2 narcosis. So usually those patients who are having moderate to severe OSA, we used to tend to put on BiPAP. Of course, our surgeons are okay with going with BiPAP or CPAP even after the surgery. The evidence also suggests that there is nothing too much to worry about the post-operative leaks or something like that from the surgical point of view. So usually that is the age. I mean, if the patient is preoperatively having significant OSA, Stop-Bank score of 6 or 8 with CPAP or BiPAP, we used to continue for at least 48 hours of CPAP or BiPAP, whichever mode patient is on preoperatively.
Shivansu Prabhakar is there. He's all yours.
Shoes back, yeah. Hi.
Prabhakaran sir. Prabhakaran sir. Hello, sir. So good
Good
to
to
see
see
you.
you. Yeah, good to see you. Good to see you, Sio.
So we Prabhakaran sir, could you please for the sake of all, tell us all about our ERAS paper, enhanced recovery paper that we had for our bariatric patients, and how do we optimize them pre-operatively, per-operatively, and also immediate post-operatively regarding the tap block
Yeah,
and
yeah.
the dexmedetomidine, all these drugs that you were saying.
Agreed, Sio. Yeah.
So over to you, sir.
Yeah, that
Yes.
was a nice time which we started IRAS in 2000, I think 17, I think so. So basically,
Yes.
the IRAS helps much better in these obese patients, sleeve patients. Even though IRAS is started in colorectal surgeries, and it's nowadays followed in almost all the surgeries. So regarding obese patients, this IRAS helps in much better post-operative outcomes. That's the most important part. I mean, like in case of a super obese or a hyper obese, right from the first visit of the patient has to be addressed by a multidisciplinary team, which includes the anesthetist, surgeon, physiotherapist, psychiatrist, and a detailed evaluation of the history and any other comorbidity should be clearly explained and addressed to the patients. And what is the type of surgery, what we are expecting from you, like spirometry and all should be taught from the first visit of the patient. Patient should be properly optimized for at least 2 weeks with spirometry and breathing exercises. And from surgical point of view, like what you will be doing the regularly, like liver shrinkage diet or dietary part. So it is basically a teamwork. Adequately, at least 2 weeks of optimization should be done. And preoperatively, what we do is we give dexamethasone for prevention of the nausea and vomiting at least, I mean, before induction. Something like right at the time of antibiotics, like half an hour before surgery.
Basically the non-opioid drugs
Yeah.
that
We
you're
go
talking
for
about, right, sir?
either opiate sparing or opiate free. Completely, we will cut
Yeah.
off the opioids. Just for in this patient, I went for opiate sparing because she's not having much of OSA. So I gave fentanyl of just 2 mg per kg just for the induction. Intraoperatively avoided, and we gave the ultrasonic subcostal tab block and rectus sheath block. So this will cover for at least 12 to 14 hours. The first crucial period where the patient will be having an excruciating pain. So that will be taken
Yes.
care by
Yes.
the block, your adequate blocks. And post-operatively, we can go for a simple NSAIDs like paracetamol. And if needed, if there is no contraindication, as 1 or 2 doses of diclofenac will be helpful. And
So the pain ladder will be starting with the like post-operatively will be mostly PCM,
yeah,
right, sir?
mostly with PCM. Yeah.
Like,
PCM is the first choice of drug regarding NSAIDs. And diclofenac, since most of your patients, for example, this is a diabetic which is controlled. When you go for a uncontrolled diabetic with HbA1c of 11, we tend to avoid much of any diclofenac kind of drugs, COX-2 inhibitors like that. Even a single dose can trigger some
yeah.
sort of AKI. So the safer one is paracetamol. And of course, when your block is fine, usually these patients will be all right. If your block regarding block, we used to add some additive drugs like dexmedetomidine and clonidine, which can potentially increase the duration of analgesia, something like 16 hours. And post that, we should be able to manage with the paracetamol. And if at all necessary, we can go for an opioid agonist, antagonist, something like a not as not a full opioid, something like a tramadol, something we can manage.
Yeah. So
Prabhakaran,
I think so. We
Yeah,
are.
yeah, sir.
Dr. Kedar Patil here.
Hello.
In the ABG, what are the parameters that you see and be cautious about the patient that this might require post-op CPAP or ventilator? What are the things that you see in a ABG? If the patient is stop bang is normal, but you suspect that there would be some respiratory element due to obesity.
Okay. Regarding ABG, sir, if the stop bank score is normal, first I will say when to get an ABG. So for all the patients, we don't ask for an ABG. Something like if it is a patient is super obese with BMI of more than 50, of course, something like 45 or 48 with poor effort tolerance, we ask for an ABG. And before that, if your baseline saturation is 95 or 94, you should always get an ABG to look for any baseline PO2 levels, if there is any significant hypoxemia and all. And baseline serum bicarbonate will give you a clue about whether the patient is having any sort of acidosis or OSA. If the serum bicarbonate is 28, definitely the patient may be having some sort of OSA, apart from the stop bank score. Next, coming to stop bank, if the score is more than 5, definitely the patient might be having some sort of OSA, some mild to or moderate or severe. So in those scenarios, we used to go for ABG. So in ABG particularly, the vital aspect to look for is PaO2, PCO2, and bicarbonate levels. If your PaO2 level is less than 55, definitely you should be very cautious, because it is almost something similar to an ALA patient, something like acute lung injury patients. I mean, those are not pathologically having disease, but because of the chronic hypoxemia, they used to tend to have adapted to that lifestyle. But still, these patients might land up in postoperative ventilation or some sort of increased oxygen requirement, which postoperatively you should have to be more cautious. So those patients will need aggressive optimization like spirometry and putting on a CPAP or BiPAP, depending upon the other parameters. The next one is your PCO2. Like I said, if your PCO2 levels are high along with decreased PO2, then they might be having some sort of OHS. The another terminology, which is called the Pickwick syndrome. These patients might be having if the PCO2 levels were high. So increased daytime somnolence, and those things will usually generally co-occur. Your PCO2 levels are high, hypertension, everything. So those times we have to straight away you go for treating the patients with BiPAP. Of course, you can go for a sleep study to further confirmation to look for AHA levels, and based on the AHA levels, you can go for CPAP or BiPAP depending upon the pathology of obstruction. So the next is this serum lactate to look for any how the perfusion is. So these are the three important parameters, sir. The first and foremost is PaO2, PCO2, your bicarb levels, and serum lactate. Based on these findings, you can decide whether to put the patient on CPAP, BiPAP, or whether the patient will land up in post-op ventilation. You can basically stratify the patient, what risk the patient may be having in the post-operative period.
So
Yeah,
Prabhakaran, sir,
sure, sir.
sir, what you had told is very, very practical and very, very much needed. Also, from the insurance point of view, if we talk about when the health insurance come into purview, all these guys ask a lot of sleep study and all these. What are the documentation that you have? So it becomes a little bit difficult because nowadays getting approvals, and we have a different bariatric insurance group also by the OSCE. And usually the insurance guys, especially if you, I don't want to name them, they are very cranky regarding the passing the. So they'll ask a lot of documentation also.
Got
Am
it,
I
sir.
not?
Got it. Got it. Sure. Got it.
So
Yeah.
yeah.
So, I mean, for insurance per se, I don't know. I don't think you might be doing some investigation. That's up to you people to decide to go for. But technically speaking,
Sir, and what about the
Shivansu, are you there? I can't hear you. Shivansu, hello.
yes, sir, I'm here, sir. Yes, sir. Yes,
I
sir.
couldn't get you. What's your question? What was you asking?
No, regarding the DVT profile,
Okay.
post-op DVT profile access.
Yeah, okay. Post-operative, the standard prophylaxis, what we are following is the similar thing. I mean, the Clexane. Usually, we used to give at least 3 days post-operatively for the normal patients like that, for morbid obese with BMI of less than 45. For super obese and hyper obese patients, extended thromboprophylaxis of up to 4 weeks has to be given. That will be followed by our team. It has to be given. The routine thing, the Clexane, which you used to give. Along with that, pre-operatively, it has to be started 3 days prior to surgery. And nowadays, there is not much significant role for your stockings. We used to, I think they must have shown you the sequential compression devices and the device, and that has to be
We saw it. Yes.
Yeah, that has to be applied prior to the surgery. And in case of supervised patients, if the patient is not okay on the POD0, it should be continued till the patient gets ambulatory. But basically, what we
So it's basically both mechanical and chemoprophylaxis.
Yeah, both mechanical and chemoprophylaxis should be continued. And ideally, that's what we did know, Shivansu, on our eras. We used to give fluids as early as possible. I mean, we used to start the fluids within 2 to 3 hours after surgery. And we try to ambulate the patients on the day of surgery. For example, now it is time is 4:30. Probably we will try to ambulate the patient by something like 7 p.m. 7 or 8 p.m. if everything is right, everything is all right. Yeah. So that way you can you will have an edge over the DVT.
Yes, sir. Got it, sir. Thank you, sir. Thank you for giving your very great inputs.
Thank you, Shivan. So it's nice talking to you. Thank you very much. See you again.
Thank you, sir. Thank you for this platform to have this interaction with you.
Thank you, Shivan. Thank you. Bye.
So I think we should move to the talk of Dr. Pradeep.
Yes, sir. I will start with our talk, sir. I'll be briefly talking about basics. I'll be covering the basics of bariatrics, sir. I'm just trying to share my screen. Is my screen visible, sir?
No.
Not yet, Pradeep. It's not visible.
Yeah, it's there. Yeah, right. It's there.
You're able to see, sir?
Yeah.
Okay, sir. Good evening, everyone. And after the excellent session of video and discussion with Dr. Prabhakaran, sir, we'll just go ahead with a discussion of basics in bariatric surgery. I'll just start with a few basic things like what is an obesity? Obesity, basically, it is an imbalance between an energy intake and the calorie expenditure. So the long-term results in an accumulation of excess body fat. This results in dysfunction of the regulatory systems. So obesity in general, it is a disease. We have to accept that it is a disease first, and it is based on complex neurohumoral mechanisms. So how it occurs? It is caused by long-term positive energy balance. It is because of an imbalance between the energy intake and the energy expenditure. This causes the fat stores. So, considering this overall burden, WHO, they have recognized in managing obesity in India that requires an active participation of all the primary care physicians. So, it is imperative that every primary care physicians, because those are the people who will be dealing with the patients on it first hand, so they have to be sensitized that obesity has to be recognized as a chronic disease. So what is the current status in India right now? Diabetic crisis, it is deepening in India. As of November 24, it is estimated that 212 million people with diabetes, which is about 26% of the world's total. We have become number one, the diabetic capital of the world. And even according to the recent ICMR study, with the Indians are more common with the abdominal obesity. This is one of the major risk for cardiovascular diseases. So, as we are going to discuss, the Indians are genetically predisposed to develop the central obesity. So this makes Indians more prone for complications like diabetes at an earlier age when compared to the others. This is in coherence with the OIA paradox, which I will be discussing later. So what is a metabolic syndrome? Metabolic syndrome is obesity with any two of it is raised triglycerides, reduced HDL, raised blood pressure or fasting plasma glucose, or even other factors like recent they changed the name of NAFLD to MAFLD, that is metabolic associated fatty liver disease, PCOS or infertility, even with OSA and related complications, which they have been detailedly described by Dr. Prabhakar just before. So what was the BMI classification? 25 was normal, 25 to 30 is overweight, and over 30 it is like grade 1, grade 2. Now it is more than 40, it is considered to be as severe obesity. So this BMI centric approach of diagnosis has a lot of limitations. So combined use of BMI and waist circumference is recommended, because this is what I've been discussing about. This is the thin fat Indian phenotype. Here you can see two persons with a similar BMI. One is of Asian origin and one is of Caucasian origin. The fat distribution, if you see, in the similar BMI patient, the fat percentage is more for an Indian patient rather than a Caucasian. So this is a thin fat Indian phenotype. It is well accepted, as the percentage of body fat and abdominal adiposity is more in Indians even with lower BMIs. So the guidelines have been modified by Asia Pacific guidelines as up to 23 is normal, 23 to 25 overweight, and more than 25 is considered as obesity. So what is the cutoff? It's like this is the similar thing what we discussed before, and I want to add a little bit about the waist circumference also. For men more than 78 to 90, and for women more than 72 to 80, that requires lifestyle measures, and more than this, definitely medical attention. First thing, we have to start with a multi-management. It includes not just the right from our dietitian, physical activity, and all those things. And now management, and last comes our surgical management. So what are these pharmacotherapy, anti-obesity medications? Recently, there are lots and lots of medications coming up with GLP-1 and GAP are already is there. Semaglutide, liraglutide. Recent one is the tirzepatide. So they are expecting about 15 to 20% of the excess weight loss. What mechanism they occur? They cause early satiety, they decrease the gastric emptying time, and stimulate the GLP-1, which is an insulinotropic effect. I'll be discussing about GLP-1 briefly in a few slides later. So this is the Ozempic, which is not available in India right now, but it is soon to be available in India in injectable form. These are available in India like oral semaglutide and injectable tirzepatide. So what is our protocol for AOMs? If we are expecting 10 to 15 kg of weight loss, so with the strict nutritionist supervision and regular follow-up protocols, we'll be putting them in high protein, low fat, low carb diet, along with the regular physical activity. So for this, the patient's commitment is more important than anything else. And these patients will definitely be, any patients who is on weight loss journey has to be supplemented with proper vitamins, calciums, and minerals. Endoscopic management, there is a role for endoscopic balloon, endoscopic sleeve gastroplasty. These are the different types of balloon. We commonly use this PATS 3 type of balloon because it has a tendency that where we can readjust the balloon after putting the balloon inside. So indications, we'll see this could offer this is a minimal invasive option for obesity, and in patients with BMI more than 27 to induce weight loss or to treat obesity related medical conditions. Even we have put balloon even so many patients for who are waiting for liver transplant donors, also in patients that qualify for bariatric surgery but have a BMI of 45 to surgery. So they may have potential risks. These patients can be used. So there are some contraindications where we cannot use the endoscopic balloons. There are previous gastric surgery, any coagulation disorders, bleeding disorders, pregnancy, and if there is a wide hiatus in it. So this is where we tell prior endoscopy is mandatory to do in before proceeding with an endoscopic balloon. So these are different balloons that is available in the markets. This is how we'll be inflating the balloon inside the abdomen. So coming to the last part, the surgical part, in NIH in 1991, it has been told that for BMI of more than 40, and we can go ahead for surgery and BMI of more than 35 with comorbidities or failed diet and exercise. If the patient has motivated well, we can go ahead for bariatric surgery. But this recent IFSO APC consensus in 2011, they have modified this guidelines. Like for Asians, BMI of more than 35 with comorbidities, metabolic surgery can be considered. Even for Asians with with comorbidities on medical management more than 32.5 also we can consider treatment. This is the same thing that has been recently accepted in 2022 ASM-based guidelines also. So what are the principles of a bariatric surgery? They decrease the caloric intake, they cause early satiety, they increasing the catabolic state, and they alters the neurohumoral enteroinsular pathways. So this is the surgery that is done to reduce the visceral fat and not the subcutaneous fat. That is a cosmetic, that is liposuction, and this is a metabolic surgery. So what is a bariatric surgery? Any surgery that is intended at resolution of a metabolic syndrome. So it includes variety of procedures usually performed on stomachs and intestines, causes profound and durable weight loss. So that is a reduction in the visceral as well as the subcutaneous fat. So this bariatric surgery was first done in 1954. It is at as early as 1954 this was described, and in 1978 by Sir Henry Buchwald, the term metabolic surgery has been defined as metabolic surgery is an operative manipulation of a normal organ or an organ system to achieve a biological result for a potential health gain. This was defined in 1978. So I just briefly talk about these four hormones. This regulates the entire body regarding on what is happening in the obesity. So ghrelin is a hormone that is secreted in the fundus of the stomach. It regulates the appetite. Peptide YY, it is secreted in the L cells in the terminal ileum. It is an anorectic hormone. Leptin, it is secreted in the visceral fat. It regulates the entire satiety. Leptin along with the adiponectin. Oxyntomodulin, it is also secreted in the terminal ileum. It increases the overall BMR of our body. So what is ghrelin? As I told you, it is an appetite hormone. It is still incompletely understood. These levels are increased even after LAGB or diet restriction, but this level significantly falls because after sleeve gastrectomy, the fundus is completely cut off and it is removed. So the level falls significantly immediately after the surgery. So what is peptide YY? I told you it is secreted from the L cells of the terminal ileum. It is an anorectic hormone. This dysregulation has been implicated in obesity. So in obese, the secretion is blunted, but it is instituted. So immediately after the bariatric surgery, what is happening? There is increase in satiety, and there is decrease in hunger. So this increases the level of peptide YY after the surgery. Leptin, as I told you, it is regulating. It is a satiety factor. Usually, if as I told you, it is secreted in the adipose tissues, that is fat. This level should be increased in the obese patients, and it should increase the satiety. But it works other ways, because in obese patients, the fat, there will be a lot of inflammation, and that will cause leptin resistance. This shares a similar pathological mechanism with that of an insulin resistance, which is happening in obese patients. So it is associated with the central and peripheral resistance. This deregulates the energy homeostasis and also the glucose homeostasis. So post RYGB, the levels fall significantly, but the satiety is maintained because the resistance has been reduced and sensitivity has been increased because there is improvement in the leptin sensitivity. Adiponectin, there is a similar kind of a hormone which is secreted by the adipose tissue. This works synergistically with the leptin and also almost has the similar this thing. Oxytocin, this increases the overall energy expenditure by increasing the basal metabolic rate. So a few words about the enteroinsular axis and the incretins. What is an enteroinsular axis? If the levels of ghrelin increases, the level of anti-incretin factor secreted in the duodenum increases. So this is kind of like a directly proportional thing. So if the anti-incretins increase, the insulin response will be delayed and there will be impaired insulin action. So what is an incretin? This slide is very, very important. I just want to, just a few seconds in this slide. You can see there are two phases, first and second phase. So what is the first phase? Immediately after a carbohydrate meal, like in 15 to 30 minutes after the carbohydrate meal, GIP is secreted. This is an incretin which is secreted, and this will regulate all our this will help in metabolizing the food particles. This is happening in the duodenum. And what happens if the carbohydrate meal was a heavy carbohydrate meal? The meal travels to the terminal ileum, and that's in that second phase, there another incretin is secreting. This GLP-1 is secreted in the terminal ileum. This also helps in regulating this. So with these two hormones, this GIP and GLP-1, all these drugs, the newer drugs of anti-obesity medications, all these have been developed with these two incretins. And this basically, that as I told you, it is an early stage, it is in GIP, and it is late stage, it is in GLP-1. So basic thing that is happening in bariatric surgery is dealing with the enteroinsular axis. So after sleeve gastrectomy, the ghrelin is completely cut off and the anti-incretins produce, and the effect of anti-incretins is reduced. So there will be weight loss. Whereas in bypass surgeries, though that fundus is not completely excised, the fundus is excluded completely. This also helps in negating the action of an anti-incretin factors, because the food directly enters the bypass the small bowel. So the anti-incretin factor is completely negated. That will lead to the food to traverse to the terminal ileum earlier, leads to secreting more GLP-1, and it causes improved insulin response. This is how the diabetes is managed in obese patients after bariatric surgery. Just to conclude things, exclusion of duodenum that results in inhibition of a putative signal that is responsible for insulin resistance. This is foregut theory because this is completely excluded. What is hindgut theory? Because there is more rapid delivery of undigested food particles to the distal bowel that upregulates the L cells in the GLP-1. That is called the hindgut theory. So just to conclude, I just wanted to tell that intestine is the largest endocrine organ of the body, and metabolic syndrome, it is a result of complex interaction of intestines, adipose tissues, and the pancreas. Bariatric surgery is not just about restriction of food intake, and manipulation of small intestines can produce metabolic effects, beneficial metabolic effects. That is metabolic surgery. And weight loss management has to be tailored as per the need of the patient with respect to the BMI and comorbidity status. It is not just about surgery. It is a holistic approach of multidisciplinary team that has to be followed. Thank you. And I take this opportunity to invite everyone to the 10th edition of Minimal Invasive Surgery Carnival GEM Lab Process that is conducting November 19th to 22nd. Thank you.
Wonderful talk, Dr. Pradeep.
Thank you, sir.
I don't think there is any questions in there. Shivanshu, any comments?
No, sir, it was a nice elaborative talk, sir. I would like to congratulate him, sir.
Thank you, sir. Thank you, sir. I think next Praveen sir will start this talk on.
Hi, Dr. Praveen.
Hi,
Good evening, sir.
Rajesh. Hi, Shivanshu. Nice to have both of you here.
Hello, Praveen. How are you?
Same here, sir. Glad to have you.
Yeah.
See you so
Hi,
long.
Kedar. How are you? Good to see you.
We've been missing you for the last 1 hour now. Let's begin.
Yes. So just getting set. Give me a sec. Yeah, so is my screen visible?
No, no. Yeah, yeah.
Not yet, sir. Yes, now it's.
Yeah. So I think today we wanted to cover the dual aspects of obesity and hernia. Of course, we've been talking about it for a very long time. So I want to take this opportunity to thank each one of you to be joining this webinar, which we've been doing on a month-on-month basis. This month covering on the aspects of hernia and obesity, something every general surgeon comes along at some point of time. And of course, the LaProSurge is coming, so this is also a kind of a roadshow towards the LaProSurge and what we can expect from this year's LaProSurge, where we try to cover aspects that I mean, not so commonly discussed aspects, but then as topics that we come across on a regular basis. So on that front, I think we've been doing this on a month-on-month, starting from January, of multiple different topics, and we felt this month we were given the responsibility to conduct this webinar, and we chose the topic that was very very favorite to us, that is about how we treat obesity and hernia together. And of course this presentation will be about, can we have an algorithmic approach in addressing both this together. Of course, when we look at obesity in general, obesity by itself is one of the single most important predisposing factor for having a primary hernia and also for recurrence hernia. And the incidence can increase up to 13 to 16% just with the presence of obesity compared to a non-obese counterpart. So that is the foundation behind which why we are trying to address obesity when, or why do we need to understand obesity in the context of hernia management. And a systematic review on ventral hernia management also clearly says that one of the most important aspects of ventral hernia complications is obesity. Alongside smoking and diabetic control, obesity it by itself is one of an important factor that increases the complication rates of a ventral hernia repair. And that is why, again, I'm trying to add more strength to the aspect of understanding obesity, treatment of obesity as an important parameter in improving the outcomes of hernia, both primary hernia and recurrent hernia repair. So, of course, the choices that is there in front of us are the hernia first approach, where we do the hernia, wait for some time, and come back, do the obesity. But the problem is the predisposing factor of obesity is not addressed, so obviously increases the chances of recurrence. The second possibility is doing a bariatric surgery first, which is get the weight reduction done, come back after a good amount of weight loss has happened, surgery becomes more easier, closure of the defect becomes more easier. That's when you can put in the hernia. But however, during this waiting period, if you have done an anatomical repair, it can recur. If you have not done, again, chances of complications like a strangulation or obstruction can be very high. So the third option is putting in a biological mesh, but I think we are in an era where we clearly know that the impact of biological mesh on long-term outcomes is very poor. The recurrence rates are extremely high. So that leaves us with the fourth option of having a composite mesh along with the bariatric surgery, which is what raises eyebrows, because is it really safe? Can I safely put in a mesh along with a clean contaminated procedure, especially like a gastric bypass or a one anastomosis gastric bypass or any other procedures for that sake? Of course, we have published a first series in the year 2012 where we looked at that doing both can be done, feasible, and they are safe. Although the numbers that we had published at that point of time weren't too big, they were about 35 cases we have published in 2012. Of course, that we really had no recurrence or mesh infection in those group of patients that we published in the year 2012. And in 2015, we published a series on concomitant bariatric surgery in recurrent ventral hernia, because at that point of time, we used to have a lot of recurrent hernias that used to come to us who were obese. So we thought addressing the intra-abdominal hypertension component, which is part of obesity, is very important to treat these outcomes of these patients. So we had published a data of about 23 patients who had multiple recurrences. And of course, you could see one of those patients had 5 recurrences. We had published in the year 2015. So 23 recurrent hernia patients that we had operated, and we had a follow-up of up to 6 months to 5 years, and none of these patients recurred when a bariatric surgery was combined with these patients. And of course, we went on to conclude that doing a ventral hernia repair along with the bariatric surgery provides promising results, especially after multiple hernia failures, because we are correcting the intra-abdominal hypertension associated with obesity. So we went on to even recommend that all patients with recurrent ventral hernias, especially after multiple attempts at repair, should be referred for bariatric consultations after ruling out other potential factors for recurrence. And of course, we had even published one of our case report on endoscopic component separation, which was anterior component separation, along with bariatric surgery at that point of time. However, anterior component separation over the years has not become so popular compared to your posterior component separation or the TAR that we commonly speak about. But again, we have done our series, which we have published subsequently. So this was a publication in the year 2019, where we had looked at 156 cases of our patients who had concomitant bariatric surgery along with laparoscopic ventral hernia repair, which we had published. And we had had synthetic mesh at that point of time. And of course, we did not have mesh infection. We had one recurrence that we had presented during that time. And of course, our new data on 350 cases is awaiting publication, is accepted for publication. And I think the article should be out very shortly. Of course, I've been consistently quoting these over the years. I go to multiple conferences. Of course, 10, 12 years before, when you speak about it, people said what I was doing was nonsense. Then with our publication, then people started saying silent. But now over the years, people have started accepting that yes, it can definitely be done. And of course, not just that, we have definitely multiple data from across the globe. And this was one of his recent systematic review that have also provided positive data that concomitant bariatric surgery along with mesh repair provide significant lower rates of recurrence without any increase in mesh infection during sleeve gastrectomy and gastric bypass. So based on this, we thought we will devise an algorithm to make it more simple, to make it more understandable. Then how do we approach a patient, especially when they come to us for weight loss or they come to us with hernia? So I'm going to show you two algorithms. The first algorithm is going to be based on patients who come to us for treatment of obesity, not for the treatment of hernia, but for the treatment of obesity, but who have an incidentally identified or an asymptomatic hernia. So these are patients who present to your bariatric clinic or a weight loss clinic who also have a hernia. So we are assuming these patients are incidentally identified or asymptomatic hernia. In here, we are going to differentiate these patients as low risk and high risk patients. A low risk patient, where high risk basically means anybody with severe obstructive sleep apnea who's not fit for prolonged anesthesia and having prior cardiac events or DBT. So these we are categorizing them as high risk, and anything other outside of these would be considered low risk. So as per the hernia classification or the EHS classification, any W1 to W2, the smaller size hernias, yes, in a low risk patient, we can combine a concomitant hernia repair with bariatric surgery. I am putting with the assumption that we have a surgeon who's trained to do a bariatric surgery or a hernia surgery, or a team who has a bariatric surgeon and a hernia surgeon who can work alongside. We should not be looking at treatment of a patients based on our qualification. Let's say I am not qualified or I'm not experienced to hernia, so I will just do bariatric. I'm not experienced to do bariatric, so I'll do hernia. I think we need to, because at the end of the day, we should be having a patient first approach. So we need to have a team who can address all the issues of a patient. So with that assumption, I'm putting this guideline or these algorithms. A W3 or a 3 plus kind of a hernia, the larger size hernias, depending on the expertise available, we recommend a concomitant bariatric surgery with a hernia repair, which is what our first choice in a center like us. And would be a recommendation. But of course, since the hernias are large, the question can arise is, would they get into complications? Because the hernia sac is so big, why don't you just wait and get it done? And although these hernias are going to take much longer time than expected, so possibly you can consider a staged approach wherein we do the bariatric first approach and the hernia later. But this is as a second option. The first option is to combine both. But now if you have a high risk patient in terms of obesity, as I mentioned to you on the top, if they have the high risk characteristics, and if it is a small hernia, and if omentum is just the content, don't remove the omentum, just leave the omental plug there. And we can do a staged approach by doing a bariatric, because a small hernia and the patient is a high risk. Why do you want to look at the hernia now? Just the omentum, it's not going to do, but don't remove the omental plug. Just do the bariatric, come out, the patient loses more weight, they become from a high risk to a low risk, and then we can do a hernia repair. But if the content is a bubble, then obviously the concept of removing the bubble and doing an anatomical repair increases the chances of recurrence, obstruction, and strangulation. So yes, although it's a high risk, we recommend a concomitant hernia repair along with a bariatric surgery when it is bowel. But if it is a W3 or W3 plus, of course, it's a large hernia. The chances of complications are lesser. So staged approach is our first choice approach, wherein we can do the bariatric surgery first, wait for some time, and then you can do hernia later. But if your critical care team, anesthesia team are extremely strong, if you can keep the patient in-house for some time, you can optimize these patients well. And as a second option, we can consider a concomitant hernia repair with a bariatric surgery approach. Of course, if the patient is also willing or the patient wants it, this can be considered. In fact, yesterday we had a high-risk patient who were planned for hernias, bariatric alone, but however, the patient, we optimized the patient quite well. The patient was with us for quite a long time. So we actually did a concomitant hernia repair along with bariatric surgery, although the patient was a high risk. Now you could be sitting in the hernia clinic or general surgical clinic where the patient is actually presenting to us with a hernia. So I'm assuming it's a symptomatic hernia because they have some pain, some kind of a symptoms. So it's a hernia is what we are presenting with, but who's also obese. Now we have slightly modified algorithm that we look at it. And if these symptomatic hernias are small, that is W1, W2 approaches, then concomitant hernia repair with bariatric surgery is the treatment of choice. But if it is a high risk, as I mentioned to you earlier, then yes, optimize the patient well and consider concomitant hernia with bariatric surgery as your first choice approach because this is a symptomatic hernia. However, if it's too much of a high risk that you don't want to take a chance, considering symptomatic hernia, now we will choose a hernia first approach, optimize the patient, and then do a bariatric surgery later. But still, we would consider optimizing and getting both together done as the first option in these patients. And if it is a W3 or a W3 plus, then these are the large hernias. This may not get into big trouble like an obstruction or strangulation. So you can do a bariatric first, or as a second option, we can consider a concomitant hernia repair with a bariatric surgery. But in a large hernias and the patient is a high risk, because this considering it a symptomatic hernia, we will do only the hernia only approach first, optimize and do the bariatric surgery later. But in complicated hernias like obstruction and strangulation, obviously we need to be correcting the hernias because that's what is most important. So a lap or an open anatomical repair with or without a mesh repair, depending on the situation. You may require an resection or anastomosis. Obviously, you don't do a mesh repair. And these patients would just, the hernia would get fixed. And then 4 to 6 weeks later, you can come back and do the bariatric surgery subsequently. So this is an algorithm that we have presented, which we will be subsequently publishing as our series once this publication is accepted, because we want to quote that series before we publish this. I think we first presented our algorithm in the recently concluded AWR meet at Chennai. And of course, we had a very good discussion. So we feel this is a very practical algorithm based on our own data that is published outside, and also bringing in all the emotional thoughts and concerns on a practical basis one might have while looking at a patient in the OPD. Based on this, we would like to conclude, yes, we might have ideologies, but we treat patients. We should not be having ideologies, but data or science behind which we look at our patients. And we need to have a very individualized, unbiased approach. Just because somebody believes it could be wrong, if somebody believes or somebody assumes this could go wrong, we should not be looking at it. I think we request surgeons to look at it more objectively, scientifically, in an unbiased way. And of course, we need to have a team where there's an hernia and the bariatric surgeon who can come together and approach these patients, or a hernia or a bariatric surgeon who's trained to operate both. If I think we need to look from that angle, like in an oncology, what we call the multidisciplinary team approach, where all the oncologists, the radiation, the medical, and the surgical come together, decide the right approach. I think we need to address in this, the hernia and the bariatric group coming together, because at the end of the day, it's not what we can do. It is about, can we do something that is going to minimize the morbidity and improve the outcomes of these patients who are already having a poor quality of life. At the end of the day, making them look better is our primary motive. So this is our suggestion at that point of time. I would like to take this opportunity to invite you all for the 10th edition of GEM Lap Research, making it much bigger this year at PSG Convention Center, November 19 to 22. And of course, the website is open, registration is open. You're free to register, and we're looking forward for a great conference covering all aspects of laparoscopic surgery, including bariatric surgery and hernia surgery, which would have dedicated time slots that will be available, and we can discuss more about it during the lab research. Thank you all for your patient listening.
Great talk, Praveen. As always, I really impressed the way you have divided the algorithm in two parts, and it's very true. Nobody has proposed the algorithm like that. Hernia first and bariatric first. Of course, there are very good papers. Even Yuri has his paper on algorithm, and basically they say the same thing, but the way you have defined the both thing, hernia first, obesity first, definitely it will be very great paper for the young surgeons and for the even experts. So, looking into your earlier paper, we have done a good number of concomitant surgery, but yes, we are yet to start concomitant surgery in form of with any bypass. Right now, we have done concomitant surgery with sleeves only. A little bit. I know it's more of a mindset, because now still there are many surgeons who are against this concomitant surgery. But there was a paper, Russian paper, that they showed that after sleeve, the intraperitoneal culture report is zero. But after any bypass, the intraperitoneal culture report is 15% positive. So, anyways, I don't say I'm right, but yes, we're yet to start combining hernia with RYGB or this thing. We have done bilateral TAR with sleeve. We have done everything with sleeve, but we'll start very soon and we'll update you.
Thank you, Rajesh, for that optimism. And I think just to address that little concern you had on that 15% positive culture thing, and of course we have quoted that paper in our previous that publication in 2019. Of course, in the discussion, that was one of our important aspects that we've addressed in that discussion, where we have ourselves quoted that publication of 15% positive culture rate in gastric bypass against 0% in sleeve. And we have also addressed why that 15% having bacteria does not translate to a mesh infection. Because presence of bacteria does not mean it is going to have an infection. Because the peritoneum has so much of immune mechanism and mechanical mechanism of filtering bacteria that neutrophils comes as a first stage and macrophages comes as a second stage that engulfs these bacteria that's going to be inside the peritoneal cavity. And these bacteria will be taken away in 24 hours. They would be killed so that they actually don't become get into infection. And also from the learnings from continuous ambulatory peritoneal dialysis, the diaphragmatic pores have a mechanical filtration barrier that filters these bacteria and makes the peritoneum sterile in a maximum of 48 hours. So in 48 hours, if you repeat a culture, these peritoneums will be negative of cultures. So just presence of bacteria does not mean they are infection. The presence of bacteria, peritoneum has an immune mechanism that can. So that is why today, even when small enterotomies happen during IPOM, even during small resections, and of course in resection rectopexies that we do resection and then we keep in a mesh. So the concept has changed. So I think just having bacteria does not translate in. But of course, when you're doing a gastric bypass, you have the gut content that pours into the peritoneal cavity. The peritoneum is contaminated. Then of course we would not be recommending. This is going to be at a controlled environment that you're not having much seepage of contents that come into the peritoneal cavity. Just opening the bowel, closing the bowel, and then we should be done. This bacteria, yes, because you're opening the bowel would be there, but then that would not become a mesh infection is what we had hypothesized and we had quoted during the entire discussion was focused on that. Of course, this publication, we are focused on a different aspect altogether.
I agree. I 100% agree with that.
So, Praveen, can I ask you whether you're using composite meshes or you're using biological meshes for concomitant bypasses and hernia?
The same composite meshes that we otherwise use. And a favorite mesh in GEM, I think from your times, it's always been Paritex mesh. So it's a regular conventional Paritex, not the biological meshes. We don't use the biological meshes at all. Of course, if it's very contaminated, any other cases, septic cases, we may not do anything and come in, but we have not been using biological meshes at all for anything.
Okay.
Simple polypropylene mesh. Kedar. When we do ETEP Reevstopa or ETEP TAR with sleeve, we use simple polypropylene midweight mesh.
No, sir. I mean, for use intraperitoneally, Praveen means to say he is using. They are using composite meshes.
Yeah. Right.
The regular
not
composite meshes,
one.
not the biological meshes. Yeah, I think any mesh should be all right. Of course, we have the Bard meshes, and we have the Ventralite from Bard, and the current Sympotex, the Paritex, of those kinds, conventional composite meshes of your choice.
One more question, Praveen. I always have a concern when there's a previous IPOM or any ventral hernia surgery done, and then we are going in for a bariatric surgery. In that case, I've not done much, maybe about 5 or 6. I always try to keep the ports above, assuming the 15 centimeter length and width. But have there been incidences that you have gone through the mesh uh, and it has caused an infection if you have done a bypass or something?
No. Please repeat your question.
So there's a hernia that has been operated previously. Let's say an IPOM has been done in the patient, and the patient has come back to you for a bariatric surgery where you're planning a bypass.
Hmm.
In that case,
Okay.
do you avoid going through the mesh area always, or it's okay to go through the mesh area, put your ports as you routinely put?
No. See, on a personal basis, if the ports require to go through the mesh, most often your ports would require to go through the mesh, because it's actually sitting in the main area where your ports have to go. So we actually go through the mesh. But then now, from at this point, this is no more a mesh. This is basically a fibrous component that is just part of your abdominal wall. So now going
Incorporate.
through the mesh does not mean that you're making the area weak and then something is going to go wrong in this patient. So of course, what is going to become weak is if you're going to use a 12 port, anything beyond a 10 has to be closed. So that principle we follow. But otherwise, going through the mesh is not like we're weakening the mesh, because it's now no more a mesh. It's like a fibrotic component.
No, once the mesh is incorporated in the body, may it be not only bypass, you can go for lap chole, you can go for hysterectomy. We have gone a quite good number of time. I have not seen any infection in that incorporated mesh.
Okay.
So if there are no more questions, can we move to Dr. Sarana Kumar?
Yeah, Sharvana, please.
Thank you, Praveen.
Thank you, Praveen.
Thank you, Kedar. Thank
Thank
you,
you, sir.
Rajesh. Thank you, Shivantu.
Thank you, sir.
Thank you, Praveen. And once again, good evening and all. Now the last topic, we'll go ahead with the technical consideration, the small tips and tricks of how to do the bariatric concomitant repair, especially the bariatric surgery, along with either ETEP, RS, or IPOM. And let us go ahead with the video presentation. Can you able to see this one?
Not yet.
Hello?
Not yet, sir. Not yet, sir.
One second. Sharing this one. Now we are able to see?
Yes, sir. Yes, sir.
Yeah. Able to see?
Yes, sir. Clearly, sir.
Okay, right. So this is a technical consideration in concomitant repair. Praveen is clearly explained regarding the concomitant repair, when to do, when not to do, and some scenarios. This is always, yes, of course, this is a common scenario for all of us when you are sitting in the obesity OPD or in the hernia OPD. It's always a dilemma, and it hot topic was for debate in each and every conferences. In unfavorable condition, as Praveen said, like obstruction or strangulation, there is no question about that one, hernia first approach. Whereas in favorable condition, like incidental finding or when the patient comes to us for a hernia, and if you are finding that the BMI is more than 45 to 50, or the other way around, when the patient is coming to our obesity clinic for metabolic syndrome, along with that incidental finding of maybe W1 or W2 hernia, symptomatic hernias. So what we are going to do that one? In that aspect, always, these are the factors to be considered, like patient's factors and the hernia factors, like so associated comorbid risk factors to be associated, and we have to evaluate, and optimization, pre-op evaluation depends on that one, whether the patient needs elective or semi-elective emergency surgery, depends on the hernial factors too. And these are all depends on the size of the hernia and the contents of the hernia too. So let us go with the technical consideration. So here, concomitant repair, that is ventral hernia repair along with the metabolic surgery. Maybe metabolic surgery, when surgery means either it is a sleeve or Roux-en-Y gastric bypass or OAGB or MGB, depends on the metabolic component of that particular patient. And the ventral hernia repair depends on the hernial factors EHS classification, either IPA plus or eta porous, along with plus or minus PCS, that is posterior component separation. Maybe modified bottom-up approach or a TOR. Anything can be added in that one. So first, let me start with the eta porous plus or minus PCS with the bariatric surgery. What are the basic steps? Always retrorectus entry into the left retrorectus entry is a common position with the optic-trocar entry, and create the left retrorectus space, midline crossover, reaching the opposite retrorectus, and followed by reaching the hernial side, dissection, and dissected out the hernial content, along with the, if there is a sac, preserve the sac for the PRS closure along the PRS, and once the PRS being closed, then create the pneumo intra-abdominally and go inside. Try to place the ports away from that EAT ambivalve on the either side, and not try to into the, but if you're going through that retrorectus space also, it's not contraindicated. If feasible, go away from the EAT ambivalve on the either side. Do the metabolic surgery, what is planned for that particular patient, and after doing the metabolic surgery, deflate completely. The pneumo has to be deflated, enter into the retrorectus plane, and close the peritoneal rents where that 5 mm or 12 mm or 10 mm trocars, as like other peritoneal rents in the PRS and the trocar sites, followed by anterior rectus closure. Finally, placement of the polypropylene mesh in the retrorectus plane. This is the standard procedure steps of eta porous with the bariatric surgery. And that eta porous, always monitor on the right side foot end of the patient, and the surgeon camera person on the left shoulder of the patient, and scrub nurse on the left side of the patient, on left side of the surgeon, and OT table on the left side. And once being done, that retrorectus plane is being created, and after that, the surgeon and assistant surgeon will be standing in between the legs with the steep reversed Trendelenburg position like this way, and camera position on the right side of the patient, scrub nurse on the same side. So we need to have two monitors, one monitor here and one monitor in the head end. So two monitors is required for the concomitant repair, right? And usually we need to have two separate trolley for hernia repair and for metabolic surgery. There shouldn't be any cross contamination of the ports. See here, so we are having separate ports and instruments, another separate ports and instruments, and one disposable trocar where you have, when you are placing the mesh, always place this disposable trocar, place the mesh over there. And this is the standard ETAP for ports placement for ETAP. This is the optic trocar, usually left subcostal region. By optic trocar entry here, entry into that retrorectus plane. After creating that telescopic dissection of left retrorectus place this 10 mm over here and another 5 mm over here for working trocars. And after the midline crossover, reaching the opposite right retrorectus plane, one more trocar, right side trocar over here. This is the standard 4-ports technique for the eta porous plus or minus PCS, right? And here this this can be used as a camera, and this to be used as for right hand and left hand working trocar as a triangulation technique. And when your camera is being placed over this 10 mm, and these two used as a triangulation technique, right and left hand working trocar. Suppose when you are having a straightforward primary ventral hernia, that is W1 in the paraumbilical region, mostly we can go ahead with that only 3-ports technique of retrorectus plane dissection, and no need of doing this one also, or the standard 4-port techniques mostly mostly we can do it with the standard 4-port techniques. Suppose if you want to do a bilateral PCS or bottom-up PCS or TOR, with for right-sided TOR, these 3 ports may be useful. And when you want to do a left-side TOR, so bottom-up PCS, these 3 ports is more than sufficient. When you want to do a left TOR, you have to place one more 10 mm and 5 mm, and opposite left TOR can be placed if needed. These are the standard ports technique. And okay, this patient came to us with established metabolic syndrome, diabetic and hypertension, with 41 BMI of 52 years, with the established GRD. The endoscopic showed grade 3 esophagitis with a small hiatus hernia with the reflux symptoms. Along with that, paraumbilical hernia of 3 into 3 centimeter with omental contents. So that's why planned for concomitant repair after optimization. That means eta porous, since it's a primary ventral hernia, 3 into 3 centimeter with wide costal margin. That's why I have planned for eta porous with RVGV in this patient, right? And here, through OptiTroca, I have entered into the left retrorectus plane. So the under telescopic dissection, left retrorectus plane is created. After that, under vision, I have placed 2 trocars. Now, standing on the opposite side, this is the crossover, midline crossover. Can see a linea alba, opposite right retrorectus muscle entered into the opposite side, and this is the hernial side. By placing the 2 trocars, and I have dissected all the contents. Now the posterior sac, I am trying to dissect and safeguard that posterior sac for, along with the PRS for the posterior sac closure, and the PRS being extended downwards up to arcuate line, because since it's a 3 into 3 centimeter dissection, hernia, I have not dissected further. See, this sac being utilized for the posterior sac closure, and I have, see, this is the one second. So it's not running, 1 second. Yeah. So this is the PRS. I've started closing the PRS along with the posterior sac. See, always the concept of closing the PRS is a tension-free closure. That's why either the tension-free closure is the mantra. That's why either you have to preserve the sac to have a tension-free closure, or doing a bottom-up PCS or TOR, depends on that one. And this is done with the 2-0 bobbed sutures. So as already I've explained to you, first I will close the PRS completely. then only we can make a pneumo inside, going inside. Otherwise, there will be some sort of leak of pneumo. So it will be very difficult for us doing the intra-abdominal surgery when you are going inside. So closing of PRS is mandatory before going into the intraperitoneum. And after that, so these are the ports placement, right? Okay, so this is the one trocar inside the abdomen, and these are the another two trocars for standard RYGB. So two 12 mm trocars, and I have kept two trocars on the retrorectus plane for my further final surgery of the retrorectus plane placing of the mesh. Now, as a standard protocol, after decompression of the stomach, after retracting, so I'm trying to reach the left crest, and always I've started dissecting the left crest attachment from the fundus over here, because left crest is a lighthouse sign when you are doing the retro cardiac, creating the retrocardiac window. That is the fixed part. And this is the Roux-en-Y gastric bypass. As a standard Roux-en-Y gastric bypass, always I have started creating a small pouch at the second vessel of that stomach on the lesser curvature. I started creating and digging deep into the lesser curvature and make sure that there is no posterior attachment and into the lesser sac. After that, so I've started creating a pouch which is around 30 to 50 ml of pouch, always not more than 5 centimeters from the OG junction. And so after that, I've started dissecting the posterior side and identifying the posterior gastropancreatic attachment, the splenic and the phrenic attachments over here. And when you are going close to this one, so that's why we have created a, see, that's a lighthouse sign. So we have created a space over that close to the left crest. After that, by placing the vertical stapler, this is purple tri-stapler. And if you are a beginner, if you want to make a proper pouch, place a bougie, and close to the bougie you can place this one. So you can see here, I'm going away from the OG junction, and this pouch is not more than 3 centimeters, right? And always make sure that mantra of the surgery is, see, we have to always that fundus of the gallbladder, always we have to take out from this one. And this is the final stapler. Usually 1 to 1.5 to maximum 2 staplers is required for vertical. That means we are doing a proper pouch. And this is the small pouch where I have made a gastrostomy now for the anastomosis. I always prefer to do a loop technique of doing GJ first. So that's why I've started retracting the omentum, which is too bulky as expected because of the metabolic syndrome. That's why I started dividing the omentum into 2 halves to prevent and to make sure the shortest distance of alimentary limb passing. And after identifying the DJ flexure up to 75 centimeters of BP limb and 125 centimeter alimentary limb, this is our routine institutional protocol. We'll make that GJ and JJ. So this is at 75 centimeter. Enterotomy is placed. Make sure that there shouldn't be any contamination. And GJ is being done. Gastrojejunostomy is being done. But 2.5, not more than 3 centimeter. Always 2.5 to 3 centimeter GJ. And gastrojejunostomy is being closed with 20 PDS or Maxon, depends. We'll prefer to do with Maxon over here because of the pliability. And this is the corner stitch where I'll use it for traction. And after that, since I am a right-handed surgeon, starting from right to left is always very easy. So this is a gastrojejunostomy, starting posterior aspect of the stomach to the jejunum, not to GG, that is gastro, not from straight vertical from above downwards, always is a horizontal from gastrojejunostomy, continuous manner. And see, if you are noting that one, so always I'll make sure that I will not include the posterior aspect of that jejunum or the stomach in that, otherwise there will be obstruction. And by giving a proper traction on the left hand side, see, I'm not tightened the sutures also till now, and because I want to see the both openings clearly to before making the suture. And this is the final knot, right? And see, once being crossed from that at the final knot, see, that is the knot corner stitch. I've once been crossed, then the knots being placed over there on the lateral aspect. So now GJ is completed by continuous manner. This is our routine for all types of any anastomosis. And this stitch is called as a Brolin stitch to prevent tension on the, so you can see here, tension on the GJ anastomotic site, all the tension being shifted over here to prevent further anastomosis, maybe like anastomotic ulcer or stricture. Now I have done the airline infusion test, followed by, after confirming that one, I'm start dividing the biliary limb from the GJ close to that anastomosis with Covidian tan, that is tri-stapler. Once being done, I'll make a small enterotomy. Okay, and after that, so our routine protocol, I'll make sure that 125 centimeter of alimentary being measured and the jejunostomy is being done, and make sure that all the alimentary limb is falling on the right hand side of the patient and the BP limb on the left side of the patient. That is most important. And then only that there will be any mesenteric twist. At 125 centimeter, made a small enterotomy. Make sure that there shouldn't be any more contamination. And jejunostomy is being done with 60 mm, either blue or white or tan stapler, tri-stapler. And after, see, steady movement, and once being done, same way the jejunostomy is being done with the continuous 20 Maxon stitches as a routine. So now we can see final stitches being placed. Make sure that extra mucosal, there shouldn't be any mucosal protrusion over there, right? And followed by, so this is the intermesenteric defect being closed with 1O non-absorbable prolin. It's a very potential hernial site. If it is not being done, there is a high chance of post-operative obstruction. So it has to be done mandatory, and will not close this Peterson defect routinely. This is mandatory. Right? Once being done, all the things being done, I've started deflating that pneumo. So this is the normal alignment. Make sure that after that, deflating and enter to the retrorectus plane. Once being inflated, so nicely, and there is a small holes, just close this enterotomy, that PRS and the peritoneal rent to be closed. Now, after reducing the pressure from 12 mm to 8 mm, I've started closing the anterior rectus sheath continuously along with the plication if required. Either you can use a Statafix or bobbed sutures, nylon, non-absorbable, or Statafix like delayed absorbable. And it has to be done completely up to the cranial end. Fully that has to be plicated. After being done, after measuring that length, depends on the length. See, this is what I want to people concentrate. Like, see, always see, we have to change the trocar, that is 12 mm trocar, disposable trocar, where I'll show you. See, disposable trocar, new trocar, change the gloves and the instruments for hernial set, and polypropylene is being inserted under vision, right? This size of the mesh depends on the retrorectus plane dissected side, and once being done, spread nicely if needed. Usually, if needed, we can make two cranial knots on either side of the PRS if needed, or otherwise no need of any sutures at all. After that, place one DT for decompression for 48 hours. Not routinely mandatory, but if needed, we can do a decompression 48 hours. This is what routinely RYGB with the ETAP is being done, right? And this is one more patient, OAGB, that is because why I am saying this one, that is RYGB with the ETAP RS, and this patient we have done OAGB with the ETAP and right side PRS, because here the indication for OAGB, see, we are not changing the indications according to the hernia or this thing. See, when the patient is needed for sleeve or RYGB or OAGB, we are having certain institution protocol, and depends on that hernial site, either IPOM or ETAP can be placed. So what I'm trying to say is there is no contraindication in doing along with the concomitant, even along with the sleeve or bypass procedures. This patient 52 BMI, metabolic syndrome with OSA, diabetic, hypertension, dyslipidemia, and complex ventral hernia, that is M3, M4, L3 with R1, right? And W1, most of the hernias with 5 centimeter of divergence of recti. See, underwent hysterectomy as well as 2 LSCS and anatomical repair. So, see, hysterectomy, anatomical repair. So that's why concomitant was planned. So in this patient, I have planned for OAGB along with the ETAP-RS and modified PCS. And same way, retrorectus plane entered and creating the retrorectus plane. See, after placing the trocars, so you can see a full adhesions below the arcuate line as expected because of already 3 surgeries in the anatomical repair. And see, once being crossover, see, hernial site is started from the M3, that is umbilicus, just above the umbilicus, and it's being, so first is always create a retrorectus plane. Go ahead and make sure that don't make sure that there shouldn't be any bubble preoperatively, or if needed, place the small 5 mm diagnostic lab, and followed by you can go ahead with do the ETAP-RS. And so this is the plane on the right retrorectus plane. So once being done, and I'm slowly entering and forwarding myself into the space of regions, trying to reach that one, but because of previous 3 surgeries, you can see a dense adhesions of that area. and this is the retrorectus plane is reached. So you can see here. So this is the hernia. One hernia is here, and we have reached almost that is the pubic symphysis. So right space of Regius is reached. From there, see you can see as pubic symphysis, space of Regius. From there, slowly we have to harvest the pelvic peritoneum and started reaching the space of Bogros. After see, you can see a very big hernia, and this is the I'm trying to reach the space of Bogros by dividing the transversalis fascia in between and making that Bogros and space of Regius into single compartment. And so see, you can see arcuate line. I've started dissecting. This is modified bottom of PCS where I have started dissecting the transversalis fascia, entering the from pre-transversalis fascia, pre-peritoneal fascia to the pre-transversalis fascia over here. I've not done a complete. See, no need to do a TAR. Just try to do a modified bottom-up approach of PCS and see that whether we are able to make sure that there shouldn't be any tension on the posterior rectus sheath. So that will be a little bit of tension. That's why I've started creating a space on the left side also with the same 4 ports technique and mild modified bottom up PCS on the left side also I've started doing. That's why I'm able to harvest at least 5 to 8 centimeter on either side of that PRS. So this is the standard 4 ports technique, and this is the big hernial sites you can see here, but outside is not so evident, but radiologically as well as and intra doing this surgery we can able to see this one. This is what when always see how big the hernia is, and after harvesting the PRS, now the tension free closure that is mandatory. So we have started doing this one by 20 barbed sutures. This is the mantra of PRS closure, tension free PRS closure. For that, PCS or TAR depends on the situation, or try to save the posterior sheath. Once being done, I've gone inside. You can see PRS being closed nicely, and so intraperitoneal gas inflated, gone inside, trochosa placed, and the liver being retracted. This is OAGB. So opposite C always as a first step decompression. So we are not deviating from our principles. Whether I am doing or Praveen is doing or any of our fellows are doing or any other consultant doing, this is the first step as a routine step. We will not deviate. And after that, I am dissecting the left crest by dissecting detaching the fundus and that part. See, this is the just opposite to the incisura, lateral to the crow's foot. I've started trying to enter into the lesser sac. So I've entered because it's a very long, see, OAGB is a long pouch, long and wide pouch and wide GJ anastomosis. What's being done? Make sure that there shouldn't be any posterior gastropancreatic attachments. Don't injure the pancreas over here. Mandatory. And this is the first 45 mm vertical stapler from the lesser curvature, and after that one more 45 mm to make sure that having the cobra head appearance of OAGB. Till now I have not asked the anesthetist to push the bougie inside. Now they are pushing the bougie inside. With the guidance of the bougie, I place the second 45 mm now. After that, under the guidance of bougie, not like sleeves, not too close to the bougie or not too far away. Make sure that there is a slightly slightly wider pouch than sleeve or Rowan by gastric bypass. Here, wider pouch, long pouch with serial linear endostaplers. Stomach pouch is being placed, and after that, see this is more than 55 BMI metabolic syndrome. This is our routine unit protocol that we are making 180 centimeter of gastrojejunostomy from the DJ flexure. Make sure that all the BP limb on the left side of the patient and the common limb or alimentary limb on the right side of the patient to prevent the twisting on the mesentery. And every 5 centimeter will be having the measurement by Karlstolz instruments we are having from the tip to Z. It's around 5 centimeter. That's way we'll be routinely doing that one. And once being done, so make a small enterotomy. Make sure that there shouldn't be any contamination. And enterotomy is opened up. And this is a wide stoma. That's why 45 mm purple stapler with the purple GJ is being done. You can appreciate the cobra head appearance, right? And so you can see nicely the 45 mm of full staple being done gastrojejunostomy. There shouldn't be any twisting on outside, and see erring on that. Sometimes the staple line should be on the left side of the patient. So as shown in that GJ anastomosis in the Rowan Y, same way by stage switches followed by gastrojejunostomy as a routine. So it's being done. Okay, this is the final few more stitches, and this is the tension free stitch, Brolin stitch as a routine. To prevent further anastomotic ulcer stricture and eventually stenosis in later stages. Always we have to do this one in any JJ or GJ. So after that, deflating the stomach. See here, one step is, I forgot to show you that usually make a anti-bleed stitch also. After that, deflating and reducing the pressure from 16 to 12 now to 18, 8 millimeter of mercury. That ARS closure being started, and here it's almost very wide hernia. So we don't include only the muscles. So that's why. So we have to. I have left behind the small sac with the linea. So being included like application and going up to the edge of this one. So this is like a reverse the application technique from right to left and left to right. Guiding my left hand and from above by giving a proper pressure and making the adequate sutures. So this has to be continued as such. See, it's being continued upwards till the cranial end where we have dissected the crossover. So this is the final, the lateralmost L3 defect is also being closed. That is because of the financial incision, lateralmost part of that causing that hernia. That's also being closed. This is the added advantage of if there is a multiple hernias, especially atypical hernias, where eta porous will be having a added advantage. And almost being done. One second. This is a and after that we have to measure with the measuring tape. It depends on that one. The mesh is being placed, polypropylene mesh, not the fixed size. Depends on the retrorectus plane and the EAT ambibm, right? And so routine practice, I'll place one drain for 48 hours. I'll take it out afterwards, right? So this is OAGB and eta porous, right? And finally, IPUM plus also with the concomitant repair can be done. It's the final one. This is standard technique where Trendelenburg position, surgeons on the head and neck side of the patient, camera first in the epigastrium, and either 5 mm, under vision 10 mm, see that hernia, and from the foot end side of the monitor, see foot end side of the monitor. So first we can surgeon on the head end side, and we can start the dissection of the hernial side, defining the defect, sac excision, and coming back to the reverse Trendelenburg position, standing on the foot end side of the patient, and with leg split, doing the metabolic surgery, and followed by again going to the head side of the patient, defect closure, and mesh placement. This is the routine for IPOM plus and concomitant repair. And for IPOM, standing on the head end side, and whereas bariatric procedure on the foot end side, monitor on the head end side. So 2 monitors. This is also from the IPOM, standing on the head end side, doing this one, and this patient is a final patient. So IPOM done elsewhere 3 years back, and they have not done the IPOM plus, only IPOM, and recurrence. EHS classifications M3W1R1 with a recurrent adhesive colic, recurrent abdominal pain, got admitted 2 or 3 times, treated conservatively elsewhere, and a repeated colic abdominal pain and SAIO, and after that was referred over here, and during the examination found to have a BMI of 39 with no other comorbidities, and underlying obesity is the major factor. With no problem is no IPOM plus, only IPOM, and with the recurrent colic abdominal pain, got 3 times admitted. That's why planned for diagnostic lab, adhesolysis, depends on the situations, either proceed with the sleeve or, and because since the patient doesn't have any other comorbidities and young female, so sleeve is more than sufficient, and depends on that one. See, if the patient doesn't have any previous recurrent adhesive colic, I would prefer eta porous for this patient. But since the patient had a recurrent adhesive colic, and that's why I planned for diagnostic lab, adhesolysis, then I can plan. That's why I've so this patient epigastric trocar, Nemo created, that's a very big hernia, and gone inside as expected, full of omental, as well as you can see a bowel adhesions to the previous placed mesh. So my first intent is I have to do a meticulous, you can see here, meticulous adhesolysis, make sure that there shouldn't be any intraotomy. So I've kept my fingers are crossed and I have kept open-minded. I have informed the patient and attenders to that. I'll do additional lysis. Depends on the bubble status and other things. We will proceed this one. And here, close to the epigastric, that means that umbilicus, there is one more hernia I can see here. I have dissected out the neck and I've started. See, you can see here one hernia well above the mesh. See, that mesh is here, is well above the mesh. And when you're going close to the mesh, as expected, that is a full of omental adhesions and the bowel adhesions. And you can use the energy sources over here in the omentum. But once you have close to the bowel, don't use any sort of energy sources. This is a important point. Always use a sharp dissection, giving a proper traction by left hand and counter traction by the pneumo already being exerted, and along with the proper counter traction by the staph muscle in the anterior abdominal wall, slow dissection, meticulous. This is the very most important aspect of doing the any sort of adhesiolisis, because if any untoward actions or anything happened over here, contamination, our whole of surgery being stopped. So you can see here completely, see there is no IPOM closure, so IPOM plus, so they have left behind the sac and they have not closed, kept the mesh, and with the mesh, because of the recurrent increase in intra-abdominal pressure, that is the 39 BMI, and the small mesh for this one, and IPOM plus not being done, that's why rupture happened, and that is the reason the recurrence being happened. So first I have to take out the sac completely to prevent further seroma, eventually the hematoma, and it can prevent some sort of recurrence too, and gives the better that anatomical configuration when you are doing the sac excision, and after that doing the IPOM plus closure, right? And this is how I'm taking out the sac completely. And after that, I'm planned for once being done, and make sure that there is no bowel injury or something. So that's why. And as a routine planned, I have started doing the sleeve gastrectomy in this patient, as already shown. So routine sleeve gastrectomy, linear stapler, and with the omentopexy. So this is most important. The specimen extraction always by the back to prevent any sort of contamination, because I have to keep the mesh intraperitoneally. This is mandatory, right? By giving the back, see, without any contamination, I have taken out completely. After that, 2 separate trolleys, and see, this thing has to be changed. That trocars, that is disposable trocar, I have to change to disposable trocar, as shown already for the mesh placement, and the 2 different trolleys for hernia and metabolic surgery. Now, after reducing the pressure from 16 to 12, now I started doing the defect closure, that IPOM plus, either with the polyamide loop polyamide, or nylon, or Statafix, anything. See, depends on the convenience of the surgeons. So I have done nicely. After that, see, I have changed the gloves and the trocar, right? This is 25 into 20 mm composite mesh with transfacial. 1 is at the end and 3 in the midline and 3 in the upper border. Transfacial. Nowadays I have changed it into 1O PDS. So you can see here. See exactly at the midline, that midline transfacial, followed by anchored with tackers. Every 2 to 3 centimeter you have to place the either mesh or tacker, since it's a recurrent area. That is what EHS guidelines recommendations, followed by few intracorporeal sutures. So I have shown you ROAGB with the etaparas, OAGB with the etaparas, or sleeve with the etaparas, or this IPAM plus. What I'm trying to say is all types of procedures can be done. So this is one more case. I don't want to go into that one, right? So what I'm trying to say is in obesity, the commonest reason for recurrence is because of thick subcutaneous layers, which leads to suboptimal facial closure or missed out multiple species defects or associated comorbidities. And the most important aspect of this one is uncorrected underlying increased intra-abdominal pressure associated with an uncorrected divergence of recti. And in this case, where we have seen there is defect is not being closed. These are the major factors for recurrence in obesity, and that's why. So we have to consider all these factors in mind before going for any recurrent ventral hernia. And these are the few papers supporting and which is being published by us in way back in 2014, that concomitant repair, and this is in 2012 of our concomitant repair paper, and this is our paper on recurrent ventral hernia in morbidly obese patients, where this concomitant surgery is being on evolving standard of care. In that, we have concluded laparoscopic ventral hernia repair along with the concomitant bariatric surgery provide promising results. So all patients with the recurrent ventral hernia, especially after multiple attempts at repair, should be referred for bariatric consultation after ruling out other potential factors for the recurrence. So this is our landmark paper of 159 cases in 2019, and in that concomitant repair is we have published our results on that one, and Praveen is already explained to you, and we are in the verge of publishing more than 350 cases in different aspects with the concomitant repair, and probably within 2 to 3 months on that one. So in our experience, see, in our bariatric surgical guide also we are having separate chapters on ventral hernia repair, morbidly obese. So to conclude, hernia in obese patient in favorable condition, we can consider concomitant approach. Whether it can be a ETAPRS or IPAM plus depends on the hernial factors, and metabolic procedures depends on the metabolic components, like either it can be a sleeve or bypass, Roux-en-Y gastric bypass, or like OAGB. So what I'm trying to say is, in favorable condition, concomitant repair is safe and feasible without fear of misinfection, definitely reduces the recurrence rates and the complications. It's definitely having the added advantage of single stage operation. But one thing you have to keep in mind, that we should have a low threshold for deferral of mesh repair, followed by in any case of concerns, and with the centers with adequate experience and expertise, definitely we all have to consider this concomitant repair. And with that, I would like to conclude my talk and the session, and I would like to invite you and make a note of it on November 19th, 22nd, our 10th GEM LaProSurg Carnival. Thank you all.
Thank you, Shavana. A wonderful talk. So, a few questions. Number one, do you feel anytime your peritoneum is falling on your field when you do bariatric procedure after you dissect everything in ETAP repair?
Yes, sir. See, actually, that's what I'll always keep 1 or 2 trocars in the retrorectus plane. Other trocars I will take out and I'll place that intraperitoneal. Once being placed intraperitoneally, creating the full pneumo with 16 mm mercury and deflating this one. And that's why after closing the PRS, I'm going inside, making this one. First few minutes, there will be a drop. After that, there won't be any problem of hanging of that posterior peritoneum while doing the intraperitoneal. That was so evident when I have shown that RYGB and OAGB with ETAPRS also.
So what we have started doing now, we put our left port, we create the left retrorectus space, and then we do crossover. Once we do crossover, we stop there. Because why you don't want to go intraperitoneal first? Because then crossover becomes difficult. So you do your left side dissection, do a crossover, and then leave there, complete your bariatric procedure, come back, and then complete the procedure. Number one. Number two, I saw you have put drain in 2 of your cases. Why you put drain? I don't think there is any requirement of drain in.
Yeah, I do accept that one. There is no need of placing any drain, but For me, see, I'll always keep 24 to 48 hours of to decompression of that space to keep close to that one, not to prevent or sucking of any fluids, to prevent that, see, suction effect. But it's not having any scientific evidence, but there is no need of any placement of drain. It's already proven results.
Yeah, because lymphatics is so strong in that area, you need not to place any drain in that, and it
Yes.
increases the morbidity. There is no second thought about it. Yeah.
Sir, before the rest of the questions and people start leaving, I would like to invite all the participants to the bariatric certification course that we have at also the ETEP course, which Dr. Rajesh Srivastav sir is a convener at the Amasicon in Jaipur. So this course is on 28th of August. That's the first day of the conference, which is going up to 30th of August. So I take this opportunity to invite all the participants for this bariatric certification course and the ETEP course that Dr. Rajesh Srivastav sir is conducting. Dr. Sarvana Kumar, I would like to ask the DVT prophylaxis that you're following now at GEM for super obese patients and for the non-super obese patients. Is it different?
Yes. Actually, see, we have to categorize depends on that that BMI as well as that other comorbidities that are high risk and a low risk, right? If the BMI is less than 50 and more than 50, and usually it is mandatory, always we'll start keeping that preoperative optimization starting by 1 week prior to the surgery. That means liquid diet, proper deep breathing exercise, and walking. And usually 2 days prior to the admission, we'll start with clutching and low molecular weight heparin in the home itself, or we'll get that admission patient here itself. And usually very high risk patient 1 week prior to that one. And if the patient doesn't have any comorbidities or straightforward, then 2 weeks followed by the post surgery, 2 weeks followed by post surgery low molecular weight heparin, or nowadays we have changed into oral anticoagulants at oral coagulants too. And if it is the super obese patient or very high risk, 3 days prior to that admission, low molecular weight heparin, followed by post-operatively minimum of 3 weeks to maximum of 4 weeks with complete ambulation. And the thing is always we'll keep the patient ambulant immediate after surgery. That means 6 hours after surgery. And the most important aspect is if it is the patient less than 50 BMI, 0.6 OD, and if the patient is more than 50 BMI, 0.8, usually the requirement is 0.4 BD. That is the requirement of low molecular weight heparin, along with the proper rehydration and the analgesics. This is our standard protocol over here. Is it clear, Sivanshu? What is your protocol?
Yes, sir. Prabhakaran sir already, like when he was discussing is this thing, we had asked about the chemo and the mechanical prophylaxis and how both of them are very equally important. So, and you have already reiterated it and reinforced it like a buttress suture in the sleeve gastrectomy. Thank you, sir.
And if there is no more questions, I think we can wind up. And from moderator points of view, if you want to add some points, Jayant and Kedar, Rajesh Sivanshu.
No, I think so. We have covered all the topics very comprehensively, sir, in these 3 hours, and most importantly, it was very much on time, and like it's like exactly 3 hours, and Pasupati and the whole GEM Televersity has done a wonderful job.
Okay.
From that end.
Right. And finally, before ending up, and this is the next month GEM Televersity on July 23rd from 3 p.m. onwards. This is Eat Up Unplugged from Basics to Brilliance by the master in that Eat Up, none other than Dr. Parthasarathi and the team. See, live Eat Up with Eat Up Basics difficult PRS approximation, how to manage, TAR, how to do step-by-step approach, and the loss of domain hernias. It's a simplified. See, I would like to see you all on that July 23rd. See you. Thank you all.
Thank you, sir. Thank you, sir. Thank you, Praveen, sir. Thank you, Saku,
Thank
sir.
you.
Thank you.
Thank you, Kedar.
Thank you. Thank you, Kedar, sir.